So that's where we get the name strep throat. It's a group A beta hemolytic streptococcal pyogenes infection of the pharynx. And as you can see, nobody wants to say that the patient has a group A beta hemolytic streptococcal pyogenes infection of the pharynx. So they just say it's strep throat. That is the type of bacterium that is responsible. It is a reportable disease, meaning we have to test for it, even though oftentimes you can look in the patient's mouth and clearly see that it is strep throat. You still have to do at least a rapid strep test on it to document it. Okay, so we're going to pick up with the endocrine system today, and then go into blood, and hopefully some cardiovascular system, maybe just a little bit. So we have a bunch of stuff to get through. The endocrine system is pretty deep. A lot of students don't really appreciate the endocrine system like they should. It has some really good points to it. The endocrine system is a system that uses hormones. And if you don't know what a hormone is, it's very simple. A hormone is a chemical message. You know, if we want to send a message from one part of the body to another part of the body, and we want to do it super fast, we send it along a nerve, sends an electrical message. But then the action is usually short-lived. So if we want an action to last longer, then we will use a chemical message, and we put that chemical message in the blood, and that is what a hormone is. It is a chemical message. And that sounds simple enough, but it's not quite that simple. The endocrine system works in a chain reaction kind of a fashion, so that one hormone causes another hormone, causes another hormone, causes another hormone to be released. And that creates a little bit of confusion. Not to mention, confusion in the learning process. Not to mention the fact that what can happen is a break along that chain that could interrupt the entire signaling. And that can cause something to not happen or something to happen. So I'm going to get right into this endocrine system stuff. If you will be ready to follow along, here we go. Where is my, okay, there it is.
Are you recording?
I am recording.
Okay.
And I allowed everyone who has the potential to record the ability to record. So you should be able to see my screen right about now. So let me start off simple here. We have, everything's sliding here. We have an organ or gland of some sort that is going to release a hormone. So when we show a hormone being released, or a hormone just in general, we draw an arrow. That indicates the hormone. And it is going to tell some other organ or gland to do something. Or it could tell some other organ or gland not to do something. Redraw, there we go. So they can be stimulatory or inhibitory. So we can put a plus sign up here also that could indicate a stimulatory hormone, circle around it, or we can put a negative sign here indicating an inhibitory hormone. So let me make this a little simpler to understand. If you're coming home from the store and you have groceries you're bringing into your house and your significant other is standing next to the door and you are carrying the last of the groceries in, you could tell your significant other, I've got the last of the groceries, please close the door. That is a stimulatory message. You're telling your partner to do something, as compared to the inhibitory message, whereas you're carrying the groceries in and you tell your partner, I still have groceries to bring in, please do not close the door. So you're giving them a signal to specifically not do something. That would be an inhibitory message. So hormones act in these two basic ways. So let's see how all that works. We are going to start out, and to keep it simple, or try to keep it simple, we're going to just stick with stimulatory type hormones. So we start out with some organ or gland, oftentimes starting out with the hypothalamus, but it will release a hormone that will tell some other organ or gland to do something. But that's usually not the end of it, because that organ or gland is then probably going to send a signal out to some other organ or gland telling it to do something. But that's probably not going to be the end of it. Oops. Because that organ or gland is going to send a signal out, eventually reaching our target organ here. So the body wants the red star to do something. So the signal to tell the red star to do something actually starts way back at the black square. So that releases a hormone that says to the blue circle, you need to tell the red star to do something. So the blue circle sends a message to the green triangle, tells the green triangle, okay, you need to tell the red star to do something. The green triangle sends a signal out to the red star, says, okay, now do something. This is the chain reaction of the endocrine system. And any failure along the way means that the red star will not do what it's supposed to do, or will continue doing something perhaps that we don't want it to do. Now, if that's not confusing enough, we are going to have some sort of notification system. So that red star gets this message. It's going to have to send a message back to the green triangle that says, I got your message, stop sending me the message. Or it might send it back to the blue circle and say, I got your message, stop sending your message to the green triangle, so you stop sending the message to me. Or it might send it all the way back to the black square that says, I got your message, please stop sending your signal to the blue circle, so he'll stop sending his signal to the green triangle, so he'll stop sending his signal to me. This is called negative feedback. It's telling it to do the opposite. In some cases, that red star gets this signal and it might say, you know what, I liked that signal. Keep sending more of it. This is positive feedback. And I'll talk about an example of that in a little bit. So you can see how this could get confusing, but wait, there's more. Because that blue hormone that's sending the signal to the green triangle in this pathway might also be sending a signal in another pathway to something else to say, okay, I also need you to do something. And at the same time, that blue hormone might be acting as an inhibitory hormone on something totally different. Saying, I need you to stop doing something. So this one pathway, starting out with a black square, eventually telling the red star to do something, can cause these release of hormones that eventually cause that red star to get the message. But some of the hormones are acting in this pathway might also be acting in other pathways at the same time, and they might be acting as an inhibitory fashion in a totally different pathway. So when we want one thing activated, we want something else to inactivate or shut off. Now, I know you're thinking, my goodness, this could get really confusing. Yes. However, remember what I said earlier, that this is a chain reaction fashion using these chemical messages, these hormones that are put into the blood. So if the red star is not doing what it's supposed to do, it might be a problem with that green hormone. It might be a problem with the blue hormone. It might be a problem with the black hormone. Maybe it's a problem with one of the red hormones that are saying, I got this signal, stop sending it to me, when it never got the signal. Or maybe the red hormone is never activated, so the green triangle just keeps sending the signal and the red star keeps overdoing something. So how could we test for this? Well, it's easy, actually. All we have to do is look in the blood. That is going to be where all of the chemical messages, all the hormones are going to be located. So we can see in the blood if all these hormones are as they should be. In other words, are they in the right amount or are they absent? And that could give us a lot of information. So this is the basis overview of the endocrine system. It is a bunch of chemical messages called hormones being sent throughout the body to make things happen with long-term effects. Long meaning longer than just contracting a muscle, for instance. So we know that if we interfere with this pathway, if we interfere with it, we're going to be interfering with it with long-term effects. And we also know that everything we put in our body has side effects. So any side effects that comes with interfering with these are going to be seen for a longer period of time. So those are things that have to be taken into consideration. So we'll get back to this in just a minute. Where is my, oh, there we are. Chapter 15, Endocrine System. Helping to maintain homeostasis. You can see why they can refer to this as the neuroendocrine system, because again, they're both really talking about sending messages, just in different ways. Hormones. Hormones are chemical messages. That's all they are. I know a lot of people think when they think of hormones, they automatically think of something that has to do with sex or masculinity or something along those lines. But they control a lot of things in the body. We will see that the female reproductive system, the menstrual cycle, is completely controlled by these messages. Well, most completely controlled by these messages. We use the term target cell, meaning these are the areas that the messages are meant to go into. And the nice thing about sending chemical messages in the blood is that blood goes everywhere. So all we have to do is put it in the blood, and eventually it'll go to our target cells, it'll go to our target organs, it'll go to where we want them to go. Now, here is an overview of what's basically considered parts of the endocrine system. I will say that there are other parts in the body that also release hormones, but they're not generally considered part of the endocrine system. And I'll mention a few of those as we go along. So looking up in the brain, we start in the diencephalon, where we find the hypothalamus, major control center, and the pineal gland or pineal gland. We talked about that before. That's the one that releases melatonin, which controls the circadian rhythm, that wake-sleep cycle. The pituitary gland, which sits in that little bony dish, the sella turcica, in the part of the cranial anatomy, I think we pointed out before. This little pea-sized gland, the pituitary gland, is often referred to as the master gland, although sometimes you'll have the hypothalamus refer to that as well. But the pituitary gland controls a lot, and it is small. And actually, it's two separate glands that just happen to have grown next to one another. The anterior pituitary gland is obviously in the front. The anterior pituitary gland, also known as the adenohypophysis, we will see releases a lot of hormones. And the posterior pituitary gland, also known as the neurohypophysis, releases a couple that I definitely want you to know about. And there's something else noteworthy here. The hypothalamus has a direct connection, that infundibulum I pointed out, I think in the neurology section, has a direct connection with the pituitary gland. So there are actually hormones that are created in the hypothalamus. There's lots of them, in fact, often referred to as releasing hormones. They sort of start the chain reaction. But some of them are created in the hypothalamus and just move directly into the pituitary gland and wait to be released from there. So those are important. The thyroid gland, that butterfly-shaped gland that is at the base of your neck, or a little above the base of your neck. If you put your fingers on the base of your neck and you swallow, you'll actually feel the thyroid kind of come up and touch your fingertips. The parathyroid glands are actually posterior. They're on the back side of the thyroid mostly. 4 small shaped glands, the parathyroid glands. And of course, we'll go into what these different ones do and what they release individually. The thymus is an interesting one. Located in the mediastinum, posterior to the bones of the sternum. The thymus actually gets smaller as we get bigger, which is a little unusual because most organs in our body, as we grow, they get bigger too. We start out with a baby-sized liver, and as we grow, it becomes an adult-sized liver, for instance. That's true with most everything in the body. However, the thymus actually shrinks down. And it doesn't just remain the same size and everything grows around it, it actually does get smaller. Plays a part in the immune system, but it is unique in the fact that it actually gets smaller as we get bigger. The adrenal glands. The adrenal glands are located on the superior aspect of each of the kidneys. Since there are 2 kidneys, we will of course have 2 adrenal glands. Then there's the pancreas. Kind of a triangular shaped yellow lumpy gland. Located in the abdominal cavity, it is found posterior to the stomach. It is tucked inside the first part of the small intestines, the duodenum. Plays a role in digestion as well. We will talk about the pancreas, where it reads islets. That means there are specialized areas within the pancreas called the islets of Langerhans, and those are the areas where we find alpha cells and beta cells and delta cells that are going to be releasing some of these hormones. And we're going to focus especially on the alpha and the very important beta cells. So we'll see those later on. And then the gonads, the ovaries and the testes. Now, of course, they're going to have functions with regard to producing ova and spermatozoa. But in the endocrine system, we're talking about hormones. So we'll talk more about the other things they do later on. So this is the basic overview of the endocrine system. Now, if you notice, it's a little different than some of the other systems. If you consider, for instance, the skeletal system. Skeletal system is a bunch of bones, and they all pretty much articulate with one another, with the exception, of course, of the hyoid bone. If you think about the nervous system, brain attaches to the brainstem, to the spinal cord, which branches off into nerves, and then nerves branch off into nerves. So they're all sort of connected. Skin, the integumentary system, of course, is just that big covering. When we see some of these other body systems, let's see, consider the respiratory system, for instance, the lungs. So we have two lungs, and there's airways attached to the lungs, and the airways attached to the areas in the throat and mouth and the nasal air cavities. So they're all kind of connected. Gastrointestinal system is just one big giant tube goes through the body. The endocrine system is different because its parts are spread all over the place. But remember, communication is easy because blood goes everywhere. So all we have to do is put something in the blood if we want it to go to another organ, and eventually it'll get there because blood goes everywhere. We're not going to worry too much about those. Steroid hormones, I kind of do want you to know about a little bit because they are made from cholesterol. And I know I keep stressing that point, and I do that intentionally. I want to remind people that cholesterol is not a bad thing in and of itself, because cholesterol is something that we need. We need to make those membranes on our cells, and we need to make steroid hormones. And because those two things actually come from the same place, they begin as cholesterol, they're kind of like one another. So when a steroid hormone meets one of these plasma membranes, steroid hormones often just go right across it. They just go right through it because they're kind of like one another. And then you can see these other different types here: the protein, the glycoprotein, the peptides, and the amino acids. As I said, hormones might have a primary function, but they do different things as well. And this is demonstrating how no matter where we put these hormones in the blood, eventually they'll get to the organs with the cells that have the special receptors that are unique to them, that are waiting for that particular hormone to come through. That's showing some hormones like the steroid hormones as they are here. And as I said before, the steroid hormones can move right across the plasma membrane, and most of them will go directly into the nucleus, with at least one exception. And then once they're in the nucleus, they will tell something to happen. In this case, it might be, as you can see here, to make a new protein, make something new. Positive change. About that already a little bit. Feedback. I want you to hear this term: prostaglandins, lipids. Prostaglandins are types of lipids that act locally. They can do a lot of different things, and everything from creating a pain sensation pathway to developing protection in the stomach from acid that is created. So they are groups of fats, of lipids that have a lot of different purposes, things that they can do. So I want you to hear the term. Pituitary gland. You can see here the pituitary gland sits inside. This is the sphenoid bone that's coming across here. And that is that little cutout is called the solotersicon. You can see the connection, the infundibulum from the hypothalamus. Okay, what else? As I said, these are two separate glands that they have two separate anatomical origins. The anterior pituitary gland originates from an area called Rathke's pouch, and the posterior pituitary gland is simply an invagination of the roof of the mouth. These things sort of just grew next to each other, and now they are in charge of releasing a lot of hormones. And did I mention this is a pea-sized gland? This is small. This also gives you a nice idea of its location in the body. The nasal cavity, you can see the nasal conchi there, the turbinates. So if you can imagine where your nasal cavity is kind of going just above and straight behind it, you can figure out where that pituitary gland is located. So really, I had another picture of the hormones. Okay, let me do it this way. I have an image. Maybe it's in the textbook. It must be in the textbook. Start out with the hypothalamus. We'll make the little black square the hypothalamus with a direct connection, that infundibulum. Hypothalamus. There's two hormones that are made in the hypothalamus that I want you to know about. ADH, antidiuretic hormone, and our good friend oxytocin. These two hormones are made in the hypothalamus, but they're actually moved down along that infundibulum and stored in the posterior pituitary gland. So technically they get released from the posterior pituitary gland into the blood, but they have their origin in the hypothalamus. Like I said, the hypothalamus actually makes a lot of releasing hormones. A lot of them start there. So let's see. Here is our posterior pituitary gland, post-pit. And then our anterior pituitary gland. Let's see, the first hormone coming from the anterior pituitary gland, we will start with TSH. TSH stands for the thyroid stimulating hormone. Kind of tells you in its name what it does. It is a hormone that stimulates the thyroid gland. It's going to stimulate the thyroid gland to release other hormones. Ones we'll talk about called triiodothyronine, or T3, and thyroxine, also known as T4, are going to be increased as a result of this message. And there's two of them. FSH and LH. Follicle stimulating hormone and luteinizing hormone. These are what we refer to as the gonadotropins, or hormones that work on the gonads, the ovaries and the testes. So follicle stimulating hormone will stimulate the ovaries to produce mature eggs, the mature ova, and secrete estrogen or estradiol, which will become estrogen. In the male, follicle stimulating hormone will stimulate the production of spermatozoa, the sperm cell. We have specialized tubes in the testes called seminiferous tubules that will produce the sperm. Luteinizing hormone, LH, is going to trigger ovulation. That's the release of the mature egg. It'll also stimulate the growth of something called the corpus luteum, which is the follicle that has just released the mature egg, filling up with fat. And that now fat-filled follicle is called the corpus luteum, which produces another hormone called progesterone. Let's see, in males, luteinizing hormone is going to cause the production of testosterone by the interstitial cells. Testosterone is the most abundant and biologically active of the male hormones. So these two work together, FSH and LH, meaning they work in the same areas, the gonads, which is why we call them gonadotropins. Prolactin is another hormone released from the anterior pituitary gland. I don't abbreviate prolactin because it's not that long. It's just a word, prolactin. Prolactin is going to stimulate development of the milk glands of breast during puberty in females, and it will also stimulate the production of milk during pregnancy. So you've probably heard of terms like lactation, and we talked about lactose, and we talked about the enzyme lactase. So prolactin, you could tell it has something to do with being in favor of milk. So in this case, milk production. This one, adrenocorticotropic hormone, or ACTH. You saw where the adrenal glands were located. They were located on the superior aspects of each of the two kidneys. And the adrenal glands have an inner part called the medulla and an outer part called the cortex. And ACTH, adrenocorticotropic hormone, is going to act on those adrenal glands, especially in the cortex, to release different classifications of hormones, different types of hormones. From one layer, there will be a release of hormones referred to as mineralocorticoids, like aldosterone. Then from another layer, there is a release of glucocorticoids, like cortisol. And then from another layer, what are released are called androgens, which are responsible for sex drive. Another hormone released from the anterior pituitary gland is growth hormone. Now, this one sounds like it causes things to grow, and you're absolutely right. Growth hormone is going to cause anything capable of growing to grow. Now, as I said earlier, these hormones work in a chain reaction fashion. So there is going to be another intermediate. There is going to be something else activated by the liver. This is going to activate a hormone in the liver that is eventually going to cause everything that is capable of growing to grow. But I think that as long as you know growth hormone eventually will cause everything capable of growing to grow, I think that's fine. The times of most growth, by the way, are 0 to 2, 4 to 7, and puberty. That is when most growth takes place in the bodies. Those are the years of growth, 0 to 2, 4 to 7, and puberty. That does not mean that 3-year-old isn't growing also, but the most growth is taking place during those other times. There's another hormone I'm not going to include here, and it's not as important. It's called melanocyte stimulating hormone. The reason I don't include it is because in females, it's responsible for causing that dark line, that linea nigra, that occurs down the abdomen during pregnancy, or the dark pigmentation that occurs on the face called chlasma, or sometimes just referred to as the mask of pregnancy. In males, there's some controversy as to what it does. And anytime there's controversy, when there's different fields of thought, I like to stick with the unknown as an answer. So if somebody asks, what does melanocyte stimulating hormone do in a male? I would say unknown action for right now until it is beyond a reasonable doubt. So I'm not going to include melanocyte stimulating hormone. So these are some of the ones, these are from the anterior pituitary gland. We haven't even talked about the posterior pituitary gland yet. There's really the two that I want you to know from the posterior pituitary gland are the ones that were created in the hypothalamus and were moved down to the posterior pituitary gland. The first one is ADH. So let's go, oh shoot, let's go like this. ADH, the antidiuretic hormone. Some of you have probably heard of medications called diuretics. And if you've heard of these medications, you probably know what they do. Diuretics are going to cause the patient to pee a lot. They're going to pee out a lot of excess water. Now, why would we want to use diuretic drugs to make the patient pee out a lot of water? If you remember, we have a water balloon that is full of water. Increased volume of water is going to increase the pressure. So if we have a patient with high blood pressure, what we can do is make them pee out some of that water. And that, of course, is going to decrease the overall volume, which is going to decrease the pressure. So we give patients diuretic drugs to make them pee out excess water. That hydrochlorothiazide, or HCTZ, or what people call the water pill, should really be called the make you pee pill, because that's what it does. So diuretic medications make the patient pee out more water. So what does ADH, the antidiuretic hormone, do? The antidiuretic hormone, ADH, oops, no, didn't mean for it to be in blue. ADH, this hormone will stop the patient from peeing out too much water, H2O. Antidiuretic hormone will stop the patient from peeing out too much water. Now, why would we do that? Understand that our kidneys filter our blood, and they do a terrific job of filtering out waste products. But in the process of filtering out waste products, we also filter out a lot of water. Think of that backyard above ground swimming pool that someone has that has a filter connected up to it, where the water leaves the swimming pool and things like twigs and leaves and dirt go along with that water through the pipes into the filter, and then those things get caught and stuck behind, and the water comes back out of the filter and returns back into the swimming pool cleaner than it was. So we want to have that water returning back into the swimming pool. And most of it, of course, does. There'll be a small amount lost in the filter and in the pipes and such, but most of it comes back into the swimming pool. Otherwise, we have to keep filling up the swimming pool nonstop. So when our kidneys filter our blood, we lose a huge amount of water with that process, just like water leaving a swimming pool. We have to maintain a certain amount of water in our blood to maintain a certain amount of pressure so we can move blood around. So we want to be able to reabsorb that water back into the system. That's what ADH will do. The antidiuretic hormone will reabsorb water back into the system so we don't pee out so much. In fact, it reabsorbs somewhere around 98% of the water that we would have lost. So what would happen then if we did something to block ADH? If we did something to block the antidiuretic hormone, which normally stops the patient from peeing out too much water, if we blocked the antidiuretic hormone, then the patient is going to pee out too much water. That's not good. It's going to become dehydrated. And there's a couple of things that do this. Caffeine will block the antidiuretic hormone, which will cause the patient to pee out too much water, as will ethanol, which is the type of alcohol found in the alcoholic beverage, like whiskey or beer or wine or margaritas or other drinks that
Good
are
question.
alcoholic. Yes.
Kind of like on topic but off topic. Do you think that is it easy? And do you think that's the reason why it could be linked to alcoholism because you're more thirsty, you just keep on drinking more and more, and then that just kind of happens?
I would say that's probably low on the list. I wouldn't discount it completely, but I
Okay.
would put it low on the list because that type of dependence is usually based more upon the feelings that are brought about by the alcohol and not so much about continually being thirsty. But
Okay.
I see how you make that connection. I'm not going to discount it. I'm going to put it on the list. It might just be low.
Yeah, I'm
But
asking because I have a soda problem, like really, and I keep drinking it, so I kind of like try to do salsa water just to get the fizz and sensation of it. But yeah, I am always thirsty. So what you're saying, I'm like, oh my God, I can relate to what you're saying. Like just drinking so much caffeine and the whiskey part and being thirsty, dehydrated at the end of the day, you wake up with that headache the next day. You just need water. I get it.
because of the dehydration.
Right.
Wow, nice connection, because that's exactly it. In fact, there was a time when in emergency rooms across the country on New Year's Day, you would see nurses and doctors and such getting IV fluids
Yeah.
and add a little potassium to it and call it a banana bag. And that bag of IV fluids would knock that hangover out like it never happened in about an hour's time, because it's going to replenish so much of that fluid, as well as some of those vitamins that go along with it. It's going to replenish so many of those things. And in fact, this has become a business now.
Yeah, it is.
Yes, if one was
Mainly
to,
in California, I looked it up. It's called
if one
IV
was to
therapy treatment,
venture
and they
out,
have vitamins in it. Yeah.
yes. Las Vegas, I think, is where it started,
Okay.
because Las Vegas is the playground for adults, where there is nonstop parties and drinking, and then people have to get back on a plane and get back into their regular lives. And
Mhm.
so some enterprising doctors thought, we could take advantage of this, and we will create a business where these patients can call us in the morning and we'll come over, or they'll pick you up, like they'll send a transit of some sort, and stick a bag of fluids into you and just knock that right out. Now, I am
Mhm.
in no way endorsing the overindulgence of alcoholic
Of
beverages.
course
I
not.
strongly suggest against that.
Right.
And in fact, if a person is going to have a couple of drinks, make sure it's reasonable and that they're responsible with their drinking, and include some water with that. So if you know you're going to have more than a drink or two, don't forget to add some water in between, because you are going to lose some of that. But yeah, good connection. That's exactly one of the main things that leads to that hangover, is the dehydration part.
Yeah.
I've just told everyone how to not be hungover anymore, and I don't
We're
want
all
people to
adults.
get.
It's all good.
I know, but I don't want people to get the wrong message and
Right. Right.
think about that. So, and I know one thing people are probably not thinking about right now is working out in the sun and sweating and losing a lot of fluids that way. But there will be a time, again, I promise you, after these dark days of winter's past, where we will be doing things outdoors, maybe going to the park, maybe going to the zoo. And the zoo is one of these places, and I use that as an example, or amusement parks, because they often have a lot of concrete walkways, not a lot of shade, and people are walking around with their children, and people are sweating a lot, especially at those really hot days. And the moms will be getting their kids some bottles of water, which is great. But sometimes they forget that when they're sweating out other stuff as well, like some of those, those ions that we do need. So we need to replace those. This is why maybe she wants to add a Gatorade into that, or a Sprite, get some of that sugar back into the kid, and some of that salt back into the kid as well. Add that in with a bottle of water here and there, and every once in a while some of that Sprite. And I say Sprite because it's not caffeinated. There's no caffeine in it, so you don't have to worry about them just peeing out more water again. So there's a lot to be talked about with the antidiuretic hormone, as you can see. However, even more comes with our good friend oxytocin, which originates in the hypothalamus, but it is stored and released from the posterior pituitary gland. Oxytocin, I don't know if you heard me say this, is our friend. We like our oxytocin, because oxytocin is going to do a couple of things. One thing it's going to do is it's going to cause what we refer to as the letdown reflex, or the ejection of milk when the baby starts sucking, or even if the baby starts crying, which is absolutely amazing to me, that a baby, it doesn't even have to be mom's baby, but a baby in another room crying can trigger the release of a hormone, mom's brain, to cause her to start lactating and releasing the milk. Amazing. But it does something else as well. Oxytocin is also this hormone that acts in this positive feedback mechanism. Remember I said the positive feedback is where it sends a message that says, I got your message, keep sending more. I got your message, keep sending more. We see this as it acts on the uterus. And that uterus is going to cause those contractions to push that baby out. Remember, those contractions start out weak and uncoordinated, but then they get stronger and stronger and more rhythmic and more coordinated and stronger. That's because it keeps sending that signal back saying, I got your message, keep sending more. I got your message, keep sending more. I got your message, keep sending more. There may, however, be a time where the doctors might want to intervene once she has passed that first phase of the first stage of labor. So she's dilated at least 4 centimeters, but those contractions just aren't as strong as they should be. So what we could do is we could introduce some exogenous oxytocin. Exogenous meaning coming from the outside of the body and going in. Except we get this exogenous oxytocin off the shelf. We don't call it oxytocin, though. We call it Pitocin. And if you work at all on the labor and delivery floor, you will hear about Pitocin a lot, because this uterus just is not making these strong contractions, and we've got stuff to do. So we want to speed that process up. So we are going to give exogenous oxytocin in the form of Pitocin. But what if mom delivers that baby just fine, and then mom delivers that placenta just fine, but then mom is having some bleeding, some postpartum hemorrhage? Now, normally, if there's bleeding, you know what to do. You put pressure on it. That makes perfect sense. Problem is, this bleeding is coming from the inside of the uterus. It's hard to put pressure on the inside of the uterus. So what you could do is you could cause the uterus to put pressure on itself. And the way that you do that is you cause it to contract more, which means more oxytocin, that Pitocin. Or if that placenta is just not speeding up quite enough, get those contractions, continue those contractions going, help it along. There's another way that this can be done, of course. You might see this happen where the doctor is going to massage the uterine fundus, tricking the uterus into thinking there's still something inside that needs to come out, which is going to send that signal of send more oxytocin, which is going to continue the contractions. They'll say it helps to shrink the uterus as well. But remember, that takes some time. That uterus started out about 3 inches in size in a nulliparous female, a woman who's never given birth. That uterus is pretty small, about 3 inches. And then it's going to stretch enough to hold a baby and a placenta and all that amniotic fluid. And then once it's done squeezing that baby out, and then it's going to shrink back down to its almost original size. It doesn't go back to its original size, but it goes down pretty close to that, which again is absolutely incredible that it does it. Remember, the uterus is not growing, it's stretching. The fact that it can do that is incredible. Incredible stuff. So oxytocin, you'll hear it as Pitocin. You'll hear it a lot. That's why we call Pitocin our friend. Helps that process along. So now all we've done was covered that master gland, that little tiny pituitary gland. Pretty amazing that it does all of that. So if you go back to this, actually, growth hormone does stimulate the liver, which is going to cause the production of these growth factors. Prolactin, I talked about that. TSH, thyroid stimulating hormone, talked about that. Adrenocorticotropic hormone, adrenocorticotropic hormone, ACTH, talked about that. And then the two gonadotropins, FSH and LH, follicle stimulating hormone and luteinizing hormone, although it doesn't include what it does in males, and it should. The hypothalamus, as part of the diencephalon, is a main starting point with a lot of hormones. As I said, the releasing hormones. It is going to start that process. Talked a little bit about that already. This is just going back to, these are sending signals back and these negative feedbacks. Now see here, it calls the hypothalamus beyond being the master of the pituitary. Okay, so it's the master of the pituitary, but the pituitary is the master gland. That's fine. ADH and oxytocin, again, these are created in the hypothalamus, but then stored and released from the posterior pituitary gland. Yeah, ADH, an older name for ADH is vasopressin. And I do include that, especially when I teach the paramedic class, because there are types of medications that are specifically called vasopressors. So then it makes sense that they know both names, but for this class, I don't usually include it. The pineal gland or pineal body, the posterior aspect of the diencephalon. Remember I said this is what releases melatonin. This is what is going to regulate that wake-sleep cycle. I said before that melatonin can be purchased as a supplement over the counter as a sleep aid. However, it does not act like an Ambien, nor does it act like a Benadryl. In other words, you will not get an immediate effect from it, like I want to go to sleep, so I'll take a melatonin tablet. It is used to regulate the circadian rhythm. So it is as a supplement used that over time, it would help regulate that biological wake-sleep cycle clock. As it gets dark, there should be a greater release of melatonin, which causes a person to become tired. I think I said before, that's why in the wintertime, when we have shorter days and longer nights, there's more melatonin released, so you feel like you have less energy and you want to sleep more, as compared to the springtime, where there's more sunlight and you feel like you want to run around a lot. Now, there is something that can also come from an increased amount of melatonin during these times, and that is called seasonal affective disorder, or SAD. And the person goes into depression during these months. And it's not because Christmas is stressful and buying gifts and nobody was there for them on New Year's Eve. It's because of this excessive release of melatonin in these patients. So the best therapy would really be to move. Move to any island named after a saint. Go someplace where you are going to have more sunlight year-round. That would be ideal. Or just go down for the winter times. That would be ideal. But most people would say, well, I can't do that. I can't move and be away from all this, my job, my family. But remember, this causes depression. And this depression is more than just, I'm sad. This depression can affect their careers and it can affect their family lives. However, there is another thing that can be done. There's a special UV light that can be purchased that will cause the brain to think that they are getting more sunlight than they really are. So it's a little box light, like sits on a countertop or on a desk or something. And the patient is told to sit in front of it while they're on their computer or whatever they're doing for 20 minutes a day, up to about an hour, but usually it's like 20 minutes a day, just to get them thinking, get their brain thinking that they're getting more sunlight. And that's pretty non-invasive, so it's actually a pretty good fix. And some people have asked, well, what about a tanning bed? That's a great question, because would the same effect come from sitting in a tanning bed for, I don't know how long you go in a tanning bed, 15 minutes, 10 minutes, something like that. Yes, it would. It would bring about that same effect. However, it would also increase the likelihood of something else. And I know you're thinking, oh, that would cause skin cancer. Right. So it can increase the likelihood of skin cancer. So that might not be the best way to go. So I'm always a little concerned when people start taking melatonin on a regular basis as a supplement, because I don't know if that could still lead to the same types of depression. I would definitely want to caution them in the old land.
Dr. Surgeon.
Yes. Hold on one second. Hold on
Okay.
one second. Let me go back to this. Okay. Yes.
Just a question regarding melatonin. Won't your body soon become like too acclimated or adjust to it and not produce its own after a certain time?
Oh, I don't know. I don't know if that's the problem, if it becomes too acclimated to it and just says, forget it, I'm not making anymore, or if for some other reason it just stops making it, like other cells might stop making other things. Maybe the cells start to die. Maybe the cells aren't getting the signal, but I do not know. Sorry, that one I can't help you with. Sorry. Anyone else have a question that I might have an answer for? That would be great. Give me an easy one. No. All right. All right. We will talk about the female reproductive cycle and the menstrual cycle in week 11, I believe. It's one of the last things. Reproductive system is one of the last things we do. It's an important one, though. The menstrual cycle is something that women need to understand, and women don't always understand it. Men get a pass. They don't understand it. That's fine. We'll learn it now. But women definitely need to understand what's happening. And it is a cycle. It's continuous. So just because they only notice a small amount of it, it's a continuous cycle. And in order for that continuous cycle to continually cycle, it needs to get the right messages at the right times for things to continue to happen. It's amazing that it ever does it right at all. Things that can go wrong. Okay, so I want to stop there because when we come back, I want to start talking about the thyroid gland. You'll hear some things about the thyroid gland, and that is an important one that we need to discuss. So I want to take a bit of a break. We're at 10 seconds. So let me pause. Well, let's resume then. And start start with the thyroid. As I said before, if you want to find your thyroid, just put your fingers at like sort of the base of your neck, right about there, and swallow, and you'll feel your thyroid kind of come up and touch your fingertips. If you look here, here is the hyoid bone. Remember, the hyoid bone is the only bone in the body that does not articulate with another bone. This is referred to as the laryngeal cartilage, as it is around the larynx. This point is the laryngeal prominence, which some people will know as the Adam's apple. So everyone has a laryngeal prominence. It's just much more obvious in men than it is in women. Sometimes this is referred to as the thyroid cartilage because it sits just above this right here, which is the thyroid. Pop it off. The anterior portion is here. If I spin it around, there would be 1, 2, 3, 4 dots of tissue, best described as dots of tissue, called the parathyroid glands, more towards the posterior aspect of the thyroid. And you can see again how it sits. You can see the trachea. We know it's the trachea. The trachea has rings of cartilage on the anterior surface here. Stabilize it. Keep it from collapsing. A little bit of feedback. And you might need to change your name too. Okay, so let's get into the thyroid. There you go. Okay. Where we left off. So you should be able to see my screen right about now. The thyroid gland. There you can see it.
Did he freeze, you guys?
That's what I was wondering.
Okay. Does he have us on
Or-
pause or what? Okay.
He's probably just not back in time, I guess.
Oh, he came back. He started the thyroid, had the little thing he was shaking his hand and everything.
I
Yeah,
was downstairs making some eggs.
Oh, okay.
I think someone should probably text him.
Who has his number? I don't even have his number.
I have it. I'll text him. I just texted him. Mommy.
Okay, cool.
He said he'd be right back. It's my box.
Okay.
That's the wrong way, isn't it? There we are. Hello. So, thank you for letting me know that I had disappeared. I am back now. I don't know why that happens sometimes, but it happens. And it doesn't really make a difference where I zoom from where I zoom. It just tends to happen. Okay, so let's see. What was the last thing you heard me talk about?
You were talking about your starting the thyroid and then you had the thing in your hand. I thought it was a mug at first.
This?
There you go. That thing. Yep. And then it just went off.
And then it just went off.
Yeah, you
Okay.
put the little slide up, the thyroid, and then there was nothing after that.
Oh, you did see the slide though?
Yeah, we did.
Okay. All right. So that's where I'll pick up again. I'm talking about the thyroid hormones, and well, I guess that's where I'll go. So thanks for letting me know that I disappeared. Hopefully that will be the only time. So you should be able to see my screen right now, and hopefully you should be able to hear me right now. The thyroid gland creates a couple of hormones, and the two that are here called T3 and T4 work together in what we call synergism. T3 stands for triiodothyronine, T4 for thyroxine. Although nobody calls them triiodothyronine and thyroxine, it's just much easier to call them T3 and T4, so that is fine. T3 and T4 both do the same thing. So they're working together for the same outcome. They both increase metabolism. And remember I said metabolism is the rate that our cells do things like create energy and create proteins, while at the same time utilizing fuel like glucose, oxygen, and water, but then also making waste products. So these two hormones, if there's more of them, the metabolism will be faster. If there's less of them, the metabolism will be slower. And in fact, T3 is much more potent than T4. It's about 5 times more potent. So we actually release more T4 than T3. But we can convert T4 to T3 if we need to. So one of the things that we need in our diet in order to make these hormones is something called iodine. And the place where we get most of our iodine is from salt. This is why on that container of salt, it reads iodized salt. We add iodine to our salt. We do this for the specific purpose to make sure that our thyroids work correctly. This became a problem a few years ago when they suddenly started to come out with something called sea salt, and everyone thought this was a wonderful thing. Except we knew that it wasn't a wonderful thing because it's still just salt. It is no more healthy for anyone. And in fact, it wasn't iodized. So they actually were selling a product that was no more beneficial at all. It was actually less beneficial, and people were paying more money for it. So no matter how much we tried to tell them, they did not listen. Now, if you look at those containers, they have to have a label on them that say has not been iodized or does not contain iodine. We want iodine in order to make these two hormones. We want to make sure we get enough of it. Now we can get some from seafood and from some plants that'll leach from the soil, but we want to make sure that we get enough. So we add iodine to our salt so we can make T3 and T4. Then there's another hormone called calcitonin that is released from the thyroid. Calcitonin is going to be a hormone that is released when the body has calcium that needs to be stored. And where do we store calcium? Well, we are going to store it in the bones. So calcitonin tells those osteoblast cells that build up bone, they're going to be told to take the calcium and put it into the bone. That is going to take calcium out of the blood. The parathyroid glands, as I said, typically 4, located near the posterior aspect of the thyroid. They release a hormone called parathyroid hormone. So that's easy enough. The parathyroid glands secrete parathyroid hormone. And one of the things that the parathyroid hormone does, the most important thing, is to regulate the amount of calcium that's in the blood. In other words, it tells those osteoclasts to release calcium from the bone and put it into the blood if it's needed. It literally does the opposite of calcitonin. So parathyroid hormone and calcitonin are what we call antagonists. They're doing opposite of one another. They're working in opposite, whereas T3 and T4 are working in synergism. They're working together. The adrenal glands. Look at these little caps on the superior aspect of the kidneys. The adrenal glands are made up of an inner layer, the medulla, which is a general term for an inner layer, and a cortex, which is an outer layer. The general term for an outer layer is a cortex, and then a capsule around it to keep it nice and protected. So you'll notice the cortex is divided into these different zona layers, although they don't call them the zona layers here, but that's what they are. The zona glomerulosa, the zona fasciculata, and the zona reticularis, going from the outside in. And each of these layers, and this is just the cortex, mind you, each of these layers is going to release a group of hormones. The outer layer is going to release a group of hormones called mineralocorticoids. It's in here. And the important one here is aldosterone. Aldosterone is going to regulate the amount of sodium in the blood. So aldosterone is going to say, hey, we got to get more salt in the blood. Well, why does that make a difference? Well, one of the things that we know is that water follows salt. So if we put more salt in the blood, then water is going to move into the blood, which is going to increase blood volume, which is going to increase blood pressure. Therefore, aldosterone, this hormone, is going to have a direct effect on increasing blood pressure. And again, that could be a good thing. If our blood pressure is low, we want to raise it to an acceptable level, then aldosterone helps to maintain that balance. Says, let's absorb more salt, get it back into the blood, and then water will come with it. Because water follows salt. The next layer in, the zona fasciculata, releases the glucocorticoids, and the one here is cortisol. Cortisol is going to play a big role in determining how glucose is utilized and where and when it is utilized. So it could also increase storage of glucose in different areas of the body. And then the inner layer, the zona reticulata, is going to release the androgens, rather than calling them gonadocorticoids. We'll just refer to them as androgens. These are hormones that drive libido, not including things like the testosterone. That's just that outer layer. The inner layer, the adrenal medulla, creates hormones called catecholamines. And that's a good term to hear. I'm not going to test you on the term, I don't think, but I do want you to hear it, because if you look at it, it's a difficult word to pronounce, but you'll hear people use that term. It's pronounced catecholamines. And in this case, epinephrine and norepinephrine are created and released from the adrenal medulla. Now, epinephrine is also known as adrenaline. This is the hormone, and norepinephrine is really just a neurotransmitter. We talked about that before. The difference between the two is that epinephrine has that extra methyl group. So norepinephrine remains more of the neurotransmitter. And you can see the pathways here. So I'm sure people have heard of adrenaline before, right? This is something that is very active in that sympathetic division of the fight or flight, where heart rate is going to increase, blood flow moves towards skeletal muscles so that you can put up a fight or run away. Respiratory rate, of course, is going to increase if heart rate increases, etc. Then we get to the pancreas. The pancreas is this kind of triangular shaped yellow lumpy organ. It is located posterior to the stomach. Now, again, remember, I'm talking about the organ, the stomach, not that big area that people refer to as their stomach, which is actually their abdomen. I mean the organ, the stomach. It is posterior to the stomach, and the head of the pancreas, this part, is tucked right inside the first part of the small intestines, the duodenum. And the reason for that is because it plays a part in releasing digestive enzymes. And then we have those islets of Langerhans. And these little islands, these islets of Langerhans, contain specialized cells called alpha cells, beta cells, and delta cells, each releasing hormones. The ones you definitely want to know about are the alpha and the beta cells, because there it is. Alpha cells release glucagon, beta cells release insulin. Those are the important ones that we'll talk about. So looking at the pancreas, it kind of has a triangular shape to it. Has a head, which is the larger part, then the body, which is the long, elongated part, and then the tail, which is the pointed part, which points over to the spleen, by the way. So if you're wondering where your spleen is located, it is on the left side of your body in your abdominal pelvic cavity. The pancreas kind of points right over to it. So you can see, well, you can't quite see in this picture, but you can see how it has these other ducts that are going to allow for digestive enzymes. So pancreas plays a big role in allowing us to absorb the food particles that we eat. Remember, they've got to be small enough, they've got to be broken down for us to absorb them. And this is where we find a lot of those things that are going to be released. Okay. So what does glucagon do? Glucagon, and remember, this is the one that is created in the alpha cells. Glucagon is released in what we call the starvation state. Now, please understand when I say starvation state, that does not mean that the patient has been in a life raft on the ocean for the past 6 days. I mean that those times in between meals, especially the stretched times in between meals, where we have to maintain a certain glucose level in our blood. That, what people call blood sugar, I call cell sugar, because that's where it needs to go. But if that level starts to get too low, well, then we need to get more glucose into the blood from our storage sites. And I said to you, one of the places where we store glucose is in the hall closet as glycogen, because it is easy to store it and it's easy to take it right back out again. Very fast to store, very fast to get out. Very easy to store, very easy to get out. So we have that amount and stored as glycogen that we can call on when we need it. And that's what this hormone does. It says, yeah, go ahead and get some of that glycogen. And you can see it stimulates gluconeogenesis, in other words, the creation of new glucose. But that's not what I want you to focus on. I want you to just sort of realize the big picture here of what's happening with glucagon from the alpha cells during the starvation state. So what happens when we do eat? When we get that cheese steak with the cheese fries and all those extra sugars and carbohydrates we're putting into our body, that is what we call the well-fed state. When that happens, we got to move that glucose around. In other words, we need a delivery guy. And who is our glucose delivery guy? His name is insulin. This is what insulin does. Insulin takes glucose by the hand, says, come with me. I know where you need to go. I will open the door for you and shove you in, because I got the code. So insulin is going to take glucose to the cells that need it, and then also to storage cells. So if there's no cells that need glucose right now, but there's a lot of glucose, insulin will say, okay, well, come with me. I know where you can go. So the alpha cells release glucagon during the starvation state. So we're going to get glucose back into the blood. The beta cells release insulin during the well-fed state. because insulin is our glucose delivery guy, and he's going to move glucose around and take it to the cells that need it and open the door so that glucose can get shoved right on in, because that's where glucose needs to be, in the cells, which is why we call it cell sugar. I'm not going to worry about pancreatic polypeptide, nor am I going to worry about somatostatin. Somatostatin just regulates. It's a regulator, which is a good thing to have, I suppose, but these two are so important, glucagon and insulin. There is a video on YouTube that I've done regarding diabetes, specifically diabetes mellitus. Diabetes mellitus is when the patient is having a problem getting glucose into their cells. There's two basic types, type 1 and type 2. Type 1 is just bad luck. Something went wrong early on. Maybe there was a virus, because if we don't know what causes something in the body, we blame it on a virus. And maybe it was that Epstein-Barr virus that caused the body not to be able to produce the insulin that it needs to produce. So those patients with type 1 diabetes mellitus, well, they don't have much of a choice. We've got to give them insulin. That is our first line of treatment. And then after that, we want to make sure they're living a healthy lifestyle. So we'll say lifestyle modifications are important. So bad luck. Type 2 diabetes and mellitus, however, this is more about lifestyle. People taking in a lot more glucose than they need, and the machinery kind of breaking down over time. So these patients, well, they might be able to repair that simply by changing their lifestyle. So if we catch that early enough, we can do lifestyle modifications and the person will be just fine. Or they might need a pill to kind of grease the wheels a little bit, get that equipment working up to par. And eventually they might need insulin. So that's why we don't call these two adult onset or juvenile onset or insulin dependent or non-insulin dependent diabetes and all this anymore. We don't use those terms anymore because of that. So we'll simply call it type 1 diabetes mellitus, type 2 diabetes mellitus. 75% of the people in this country right now who have diabetes mellitus have type 2. 75% of the patients in this country right now who have type 2 diabetes mellitus have type 2, which means they could have stopped it, prevented it altogether, reversed it. All they had to do was change their lifestyle. And the problem is that they aren't afraid of diabetes mellitus. That's the problem. Because when most people think of diabetes mellitus, they think of a person who has to stick their finger, check their blood sugar, be careful what they eat, stay away from sweets, maybe take insulin. And that is the most polite version of diabetes mellitus. And it shouldn't be so polite. People should be terrified of diabetes mellitus. And if there is a family history, especially of type 2, then they should be super terrified of diabetes mellitus. Because what do? We cut off their legs. These patients go into kidney failure. Then they have to go into dialysis. They go into heart failure. I strongly suggest watching the video that I have on YouTube about diabetes mellitus, because I wish people knew the truth. I want people to know the truth. The truth is it's terrifying. You should be afraid of it, especially type 2. Yes.
Can type 2 diabetes be reversed or only type 1?
Oh, no, type 1 cannot be reversed. Type 1
but
cannot
type
be
2
reversed
can
at
be.
all. Type 2 absolutely can be. It can be prevented altogether.
Okay.
All we have
So
to do is change a person's lifestyle. The problem is, how do you get a 40-year-old over-the-road truck driver who's working 10 hours a day, who only stops and eats at those fast food restaurants to change his lifestyle? He's going to say, but doc, can't I just get a pill?
right.
I don't want you to have a pill.
Right.
Right.
So do you think, okay, so pretty much it's a lifestyle change that has to happen. Do you think keto is one way to do it?
No. No.
Oh,
The keto diet, no. No, the way to do it is much simpler than that. The way to do it is to eat healthy and exercise. That's it. And
that's it. So no crazy fasting, no
we
trendy
all
diets.
know, every one of us knows what healthy eating means. That pyramid, that food pyramid that we learned in 3rd grade, that stands. Now, granted, there have been some changes over the years. For instance, we want to make sure we eat lean meats, even lean red meat. We want to make sure that we're eating, lower fat dairy products. And we want to increase the amount of good fats that we take in other words, those unsaturated fats. But yeah, it's basically the same thing. And we knew this back in kindergarten, because what did we do? We had a nutritious lunch, hopefully, and then they sent us out to recess to play, run around, eat healthy and exercise. That's it. And over the years, and I mean, since, back when I started learning about all of this stuff back in the 1920s, lifestyle was much more different. People didn't have access to food like they do now. And the quantities of food were much smaller. And they walked around a lot more. They spent a lot less time watching television because there wasn't television. They spent a lot less time on their computers because there wasn't computers. So they spent a lot more time being active and less time in inactivity. And because of that, they weren't as fat as we are now. I'm not including myself in that because this is all muscle. You can't really, it's hard to tell, I know, but it's solid muscle, just trust me. Maybe a little bit of donut in there also, but mostly muscle. It's mostly muscle and donut. But anyway, if you look at old real films, like films from the, I don't mean like a movie, but like documentaries from like the 1930s or 40s, and they show like the streets of New York City or streets of Philadelphia, look at the people. Look at the sizes of the people. They were a lot smaller then, a lot thinner then, as compared to what we are now. And the problem is that people don't understand what they're eating. The example I like to give, and I know I'm getting off topic, but this is kind of important. The example I like to give is the mother who's giving her child chocolate cake for breakfast, and then chocolate cake for lunch, and then chocolate cake for a snack, and then chocolate cake for dinner, and then chocolate cake for breakfast the next day, and chocolate cake for lunch, and chocolate cake for a snack, and chocolate cake for dinner. And then the next day, chocolate cake for breakfast. Well, you get the idea. Most of you would say, well, that's a bad mother. She shouldn't be giving her kid chocolate cake for breakfast, lunch, snack, and dinner every single day. But the mother will argue and say, well, chocolate cake has eggs. Eggs are good for you. Has glucose. We need sugar. It has glucose in it. Has milk. That's a dairy product. And you'll say, okay, yeah, that's all true. But it has 99% of garbage and 1% of good stuff. And we don't want that. We want to sort of flip it a little bit. We know that chocolate cake is delicious. First of all, I want to put that out there. Secondly, we know that chocolate cake is a treat. It's not a meal. It's something you have once in a while. Well, the reality is she's not giving her child chocolate cake for breakfast, chocolate cake for lunch, chocolate cake for a snack, and chocolate cake for dinner. She's stopping at that restaurant, I don't want to mention the name because I don't want to get sued, but you're loving it, and gets her child a waffly breakfast type of a sandwich. And then at school, the kid has lunch where he gets basically deep fried chicken fat nuggets, which is mostly deep fried chicken fat with a little bit of chicken thrown in there. And then for a snack after school, he gets a bag of Doritos or Pop-Tarts. And then for dinner, dad brings home something in a styrofoam container. The problem is they think all of those things are food. Those things aren't food. Those things are all chocolate cake. They have the same nutritional value as chocolate cake. It's a lot of bad stuff, little tiny bit of good stuff. And before any of you start trying to defend some of these places and say, well, you know, some of those places do sell salads and you can get carrot sticks. How many times have you sat around thinking, man, I am so hungry, I'm going to go through the drive-thru and get some carrot sticks? You didn't. Not from that place, at least. You probably thought, I know what I could go for right now. 2 all beef patties with some special sauce and lettuce and cheese, pickles, onions on that sesame
On a
seed.
sesame seed bun.
That large Mac sandwich. Again, I don't want to say the name. I don't want to get sued. And don't get me wrong. I'm not saying that those things are bad. In fact, I am planning a trip to that restaurant sometime in the very near future because of that special shake that comes out once a year. Literally, the last time I went there was last year at this time to get that and to get a meal because they do have some really good tasty fries. But the food is so unhealthy. It's mostly bad stuff. So it should just be a treat. It's not something to be eaten every day. But mom doesn't realize that. Dad doesn't realize that. They think those things are real food. And that's the problem. And that's what's leading people down this path to where they're getting not just overweight. Overweight is one thing. But the real concern is the diabetes mellitus that comes with getting all of that junk food into them. That's what I'm more concerned with. What's happening on the inside? I don't care how they fit in a swim costume. My concern is what's going on the inside. So this is, I should have just made you watch the video on diabetes. This is a problem in this country that you don't see in a lot of other countries because they don't have the access to food like we do. You know, again, growing up in my days, back in the 20s and 30s, if you were hungry at 9 o'clock at night and there was no food in the house, you just waited until the market opened the next day. Then you walked to the market and you bought some food. Now, if you're hungry at 3 o'clock in the morning, you can get DoorDash or Uber Eats or somebody to deliver a pizza to your door at 3 o'clock in the morning if you wanted it. While you're still sitting on the couch watching a movie while scrolling through your tablet and texting on your phone. If we wanted to talk to our friends, we had to walk down the street, knock on the door just to find out that they were at home. So unfortunately, all these things that are making our life easy is making our life too easy. We got to get back into some difficult times, meaning you got to get back out and move around a lot more. Anyway, I don't want people saying I should have listened to Dr. Sturgeon. I would rather have people saying, there was a guy in one of my classes, I don't remember his name, but because of what he said, I'm much healthier now. I would rather you forget me altogether, but remember what I said, rather than not listen to what I say, but remember my name. I'm not that important. I'd rather you be healthy and just go, I don't know, some guy. Granted, he was charming and funny, but I don't remember his name. But because of him, I'm now living a healthier lifestyle. That's much more important. That's what I want for everybody. No charge. All right. So the pancreas, we can see how these cells coming from the alpha cells from the pancreas and the beta cells from the pancreas are controlling these two. Notice something else about glucagon and insulin. They are antagonists. They are working against one another. But again, even though they're working against one another, just like we saw with calcitonin and parathyroid hormone, they can still be working together. They say, well, wait a minute, if the other two were synergism and they were working together, that makes sense, but how could these opposites be working together? Think about that shower that we talked about a long time ago when I was discussing homeostasis. And I said, when you take a shower, you turn on hot water, but you also turn on cold water. Two opposites, you can't get much more opposite than hot and cold, but you get them working together at just the right temperature to get the shower done. And sometimes you have to turn one way down and sometimes you have to turn one way up to balance it out. But you're using these two opposites to maintain this perfect environment. So the same could be said here. It's not that your body's releasing just glucagon or just insulin, but they're working together with this fine tuning of which one do we need more of right now, which one do we need less of right now. Stuff to know. Okay, the testes. Seminiferous tubules. Oh, they're not in the, I thought there was a picture coming up. The seminiferous tubules is where we have germ cells, originating cells that are eventually going to turn into sperm cells. In fact, from one of those germ cells, we can create 4 separate sperm cells in this meiosis process that we'll talk about later on. And then the interstitial cells are the ones that create testosterone, which I said before is the most abundant and biologically active of the hormones in the male body. Now, women also create small amounts of testosterone, along with a lot of estrogen. Men, they don't produce estrogen, but they do convert and make estrogen, small amounts of estrogen. So it's a little bit different in men. But estrogen and progesterone are 2 really, really important hormones that are created in the ovary that are going to help regulate that menstrual cycle, for instance. And in doing so, that's also going to increase the likelihood of things like pregnancy. Estrogen has that job also of developing sexual characteristics, just as testosterone does in males. So the anterior pituitary gland releases FSH and LH, follicle stimulating hormone, luteinizing hormone. Those 2 hormones act on the testes and the ovaries to cause the release of things like estrogen and progesterone or testosterone. And actually, the hypothalamus starts the whole process with the release of a gonadotropin releasing hormone that causes the anterior pituitary gland to release follicle stimulating hormone or luteinizing hormone, which then causes the production of things like estrogen and progesterone. The placenta is the connection from the baby to the uterus, to mom, I should say, because it implants in the uterus, and the blood supply coming from baby goes through the placenta. And as it goes through the placenta, the cells from the placenta pick up nutrients from mom's uterus. And then those nutrients go from the placental cells into the blood and return back to the baby. Remember, mom's blood and baby's blood do not mix, at least not until I hope that's not disappeared. Okay. At, yeah, at least not until delivery. Mom's blood and baby's blood do not mix until delivery. But the placenta has another important rule, a couple of important rules actually. One of the first ones is the early placenta. When it first implants, it's called the chorion. It's not in here. Okay. The chorion is the pre-placenta, we can call it. And it is going to release a hormone called beta human chorionic gonadotropin hormone, or human chorionic gonadotropin hormone, or just HCG. So why does the placenta release HCG? HCG does two things. HCG is going to send a signal that says, hey, we're making a baby. We're going to need more blood supply here. So make sure you send a lot more blood supply this way. Then HCG is going to do another thing. It is going to freeze the menstrual cycle. Now, why would we want to freeze the menstrual cycle? Well, because one part of the menstrual cycle is the ischemic phase, where she cuts off blood supply to the uterus, especially the endometrium, the uterine lining. And when that happens, all that extra tissue that was created is now lost during the menstrual phase. If we did that while there was a baby there, well, then the baby would get lost. We would cut off blood supply to the endometrium, cut off blood supply to the baby. The baby wouldn't survive and would be lost. So we have to freeze that menstrual cycle. And then later on, the placenta produces estrogen, which continues that process. Originally, it's the HCG that does that. So if that early placenta, that chorion, is releasing HCG into mom's tissue, into her blood, that means it's going to get filtered out of her blood at some point, in some way. So all we have to do is look for it. And we do that by having her pee on a stick, for instance. And if that hormone is there, then there is a positive pregnancy test. So if that Dollar General store positive pregnancy test comes back positive, she is pregnant. And that is true 99% of the time. And I say 99 because the other times when it's not true and so she's not pregnant, it's not good news. There's something else that's causing this to happen that's bad. So it's not going to come back as, well, there's nothing at all wrong and she's not pregnant, even though it shows she's pregnant. No, 99% of the time, almost 100, pushing 100% of the time, when that says she's pregnant, she's pregnant. And if it's not because she's pregnant, well, then it's something else that's not good. This is also why, and I know you're not going to believe me on this one. This is also why a woman cannot have a period while she's pregnant. It cannot happen. A woman does not have a menstrual period while she's pregnant, because that cycling stops, because it has to. If it doesn't stop, there would be an ischemic phase, and the ischemic phase would be the thing that happens right before the period, the release of all that extra tissue and blood, which means the baby would come along with it every single time. And I know some of you don't believe me. I'm sorry. I know some of you will say, well, I know someone who had their period. No, they didn't. They didn't have their period through their entire pregnancy or halfway through their pregnancy. Early on, there's something called implantation bleeding. That's a little bit. And then if there's more bleeding throughout the pregnancy, it's usually from the cervix, but it's not menstrual bleeding. or wrong. Of course, you can always look it up, see if I'm lying. You'll find out that I'm not. Hopefully. Don't ask your friends on Facegram or Instabook or any of those things, because they'll say, oh no, I had it. No, you didn't. Okay. The thymus. Thymosins, especially released from the thymus. Not going to worry about thymopoietin, but thymosins act with regard to the immune system. However, the more important thing I want you to know about the thymus, actually two things I want you to know about the thymus. Its location, first of all, in the thoracic cavity, in the area we refer to as the mediastinum, that central part of the thoracic cavity, posterior, I don't know why it's saying there's a picture there, not posterior to the sternum, the thymus. And that it gets smaller as we get bigger. Don't worry about leptin. Let's see. Cholecystokinin, CCK, that's an interesting one. And Grayling has undergone a lot of research over the years with regard to overeating and such, but cholecystokinin is going to act on the gallbladder to release bile in the presence of a fatty meal. When a fatty meal comes through the stomach, cholecystokinin tells the gallbladder we have got a lot of fat coming through. We need to break down that fat. So we will secrete bile, which will do just that. As you can see, the heart also secretes hormones. Again, I'm not going to go into the hormones of the heart. Later on, I will talk about hormones of the, let's see, liver, well, no, probably the kidneys, because the kidneys release an important hormone. That's it, right? Kidneys secrete an important hormone that I do want to talk about. So for right now, I kind of want to stick with the hormones that are specific to the endocrine system, but I do want you to see that other organs in the body can also secrete hormones as well. They're just not generally considered part of the system. Okay. Oh, way too far ahead there. There we go. Questions about the endocrine system? Stop it before we get started here. So I apologize, I'm going off on the rant about diabetes mellitus a little bit and diet, but I think it's important. It's important to be able to see that and understand that this is one of the problems in this country. And again, I have no ill feelings towards these places that serve this food. I'm not saying they're bad in and of themselves. I'm saying those are supposed to be meant for a treat. You eat them once in a while, not as a meal, not every day. And unfortunately, people don't understand that. And they think that that is real food, and it just isn't. So.
Dr. Surgeon.
Yeah.
We used to recommend that children, and I remember recommending this to our patients via the WIC program, that they need juice every day as meal replacement or in between snacks, and it has to be 100% juice. Nowadays, we don't offer juice anymore. We offer more water, and actually kids don't need and shouldn't have juice.
No, kids still need juice, just not as much of it. Because unfortunately, that people had gone to the other extreme, right? Where that's all they were getting, juice all the time. And unfortunately, a lot of the juices that they were getting were full of extra sugars. You know, if you look on a label, it won't say hey, guess what? We've added extra sugars to this juice, but it'll say things like corn syrup. You know, and you think, well, corn, hey, that's a vegetable. Corn is like the candy of the vegetables. It has a lot of sugar and not the most nutritional value. So I'm not saying that there isn't nutritional value, and I'm saying it's just lower. There's other better vegetables to have. But kids still need the other things that you get from juice. Because remember, what are you getting from juice? You're not just getting the water part of it and the sugar that comes with it, the fructose that you usually find. But they also get some of those other vitamins. Think about vitamin C, for instance, very obvious one. They just need it.
Oranges.
They just need it.
Fruit.
Yeah, they just need it in moderation. Yeah, and there's definitely truth in that. And going off on that, in fact, a good example is bananas versus banana chips.
Yeah.
What's the problem with a kid eating banana chips as a snack? You think, hey, they're just dehydrated bananas. That's really good. It's a healthy food alternative. The problem with that is when you suck that water out of that banana, you've now created something that has the same amount of sugar as that little piece of banana originated with, but without the water, it doesn't have the filling effect. So if that kid ate a whole banana, they might be done with banana going, man, I am full. But if they're eating banana chips, they have to eat more banana chips in order to get that same feeling of fullness. And in the process, they're getting a lot more sugar along with it. So that kind of goes along with the eat the orange rather than drinking orange juice, because you're getting, you're still getting the nutrients from it, but you're not getting all the concentrated sugar, is what you're saying there. And there's definitely some truth in that. But there's still a benefit from fresh squeezed stuff, from getting that fresh squeeze, especially juice. It's easier to take a pill with a glass of orange juice than with eating an orange. And some things like iron pills, you definitely want to take an iron pill with a glass of orange juice, because iron doesn't get absorbed well in the absence of vitamin C. But you could just eat an orange first, or eat a cup of strawberries. There's actually more vitamin C in a cup of strawberries than there is in an orange. You could certainly do that.
That is funny because I'm on iron since being on the thinners, and that's what they told me: consume more vitamin C before taking it.
Yeah, it doesn't get absorbed in the absence of vitamin C. Not well. You'd have to really take a huge amount of it to force it across, and that's not a good idea, because iron is going to do one of two things. You're either going to throw it up or it's going to constipate you. So it's better just to take it with vitamin C and get it absorbed well. Good. I'm glad they told you that. Sometimes people forget. They forget the basic physiology. The juice you want to stay away from is grapefruit juice, because it inhibits an enzyme in the liver. And that enzyme in the liver is an enzyme that is often utilized in the metabolism of medications. So
I read that. I asked my doctor that, and they said, oh no, with these newer ones, you don't have to, there's no diet restrictions.
You don't have to worry about it. Good. Yeah.
But then I researched myself and saw that it is recommended that you shouldn't have. And I'm like, how does my doctor not know that? But
yeah. And maybe there's truth in that. And it's not for all medications, for sure.
Just that one. I know Coumadin you really shouldn't. Good thing I'm not on Coumadin, but that's a really big one. You shouldn't have it.
What was the other thing I was thinking about? That interfere. Oh, I know what it was. I was thinking about antibiotics interfering with birth control pills. So if she's taking birth control pills, if she takes antibiotics to treat something else, she needs to be aware that that is also competing with the enzyme, meaning, and it's going to win the competition. So the enzyme is not going to be able to work to metabolize the birth control pills, which means they'll basically be useless. So she'll be at an increased risk for pregnancy during that time. But that wasn't food related, but I was just thinking, what else interferes? And I should mention, that's what it was. All right, well, and someone had asked about the different diets, and there's always different fad diets that come and go. But the reality is you have to stick with the basics. It's really, really simple. And unfortunately, people don't. They jump on a lot of these different food diets and they think that's something better. For a long time that, what was the low carb diet that the doctor created, Atkins diet. And I remember learning about this in medical school in the biochemistry, and it's tricking the body into a diabetic state. It's incredibly dangerous to do this.
That's what keto replaced. Keto replaced Atkins. It's the same thing. Your body needs carbs.
Yeah.
What happens when you come off of that diet and you start eating carbs again? You're going to put that weight back on.
Yeah, and I think I mentioned at some point that about 65% of your diet should be carbohydrates. We have to have carbohydrates. People think carbohydrates are innately fattening. They are not. They're not innately fattening. It's just when people take in too many of them, and they take in too many of the fats. That food from those places, I don't want to mention the names, have a huge amount of fat. That large Mac sandwich, my goodness, the amount of fat that's in that. Really, a person only needs about 24 grams of fat a day. That one sandwich has about 30 grams of fat in it. And then if a large fry accompanies it, that's another 30 grams of fat. Just in that one meal, you get 2 days worth of fat just in one meal. And that's if you don't eat anything else with fat in it all day long. So yeah, there's unfortunately people keep jumping on these different diets because they think, well, this one's better than that one. Or again, I see people, saying, well, I'm on an all protein diet. It's like, well, why do you think that's helpful? Well, look at the people who are on it. They're all ripped and muscled. Yeah, they're in the gym for hours at a time, working out. They're working out every single day. They need that extra protein. You drinking that protein shake's not going to help. It's just going to store that extra protein is going to store as fat. And I got the Lippincott biochemistry to prove it. But anyway, I digress. So the endocrine system, I think, is incredibly interesting system. It's not as complicated as people like to think it is, especially if all you think is, well, these are just chemical hormones messages that are in the blood. So all you have to do is check the blood and you can see which ones are high and which ones are low. If a person has hypothyroidism, low thyroid hormones, well, that means their metabolism is going to be slow, which means things are going to slow down for them, which means we're going to see weight gain in them often. They're going to feel fatigued all the time. I have low energy state. They're going to have constipation. Things are going to slow down everywhere. And we're going to treat it by giving them thyroid hormone, synthetic thyroid hormone, literally called Synthroid. That's going to increase their metabolism. People with hyperthyroidism, things are going too fast. The problem with that is the only real way to correct that for right now, the best way is to remove the thyroid. But then we took a person who was hyperthyroid, now we just made them hypothyroid because we took it out, which means now we have to give them synthetic thyroid to regulate their thyroids again. And oftentimes the parathyroid hormones will be taken out at the same time, not intentionally, but they're small. So trying to spare those is difficult, although there's an FDA procedure that came out about 4 years ago, parathyroid sparing robotic surgery. I twisted my tongue there a bit. Parathyroid sparing robotic surgery, I think it's called, something like that, where they can actually do that, which is pretty awesome. But if every child in the United States tested for congenital hypothyroidism, because if they are, that's bad. That can lead to what's called cretinism, which is a type of mental retardation. So that's bad. Good news is all you got to do is give them synthetic thyroid. and they'll be normal, they'll be fine. That's why we test every child in the United States for congenital hypothyroidism. Because if they have it, that's bad. But if they have it, it's an easy fix and they'll be fine. So it kind of makes sense. Well, we'll talk about the pancreas insufficiency more in the digestive system then, because we talked about it. So okay, I think we're good for now. What time is it? Let's take a bit of a break before we get into blood. I love talking about blood. It is so important. Hematology is incredibly important. So let's see. Let's pause this for now. Okay. We should be back, or just about back. Hopefully back. We're going to start moving into blood, maybe even a little cardiovascular system, but we're going to start with blood. And blood is important. So we'll start off real simple. Okay, you should see my screen right about now. Let's go to all this. Because the question that I would ask what does blood do? It's a very simple question with actually a very simple answer. It has a one-word answer. What does blood do? It transports. That's what it does. That's its job. And where does blood go? It goes everywhere. So what is it transporting everywhere? It's transporting things we need, and things we don't need / or want. So it's going to transport the things that we need to the places that they need to go. And then it's going to transport things like waste products that our body has made, that our cells have made. And it's going to transport them to areas where we can get rid of them, like our lungs, so we can breathe out that carbon dioxide that we created, or at least some of it. And we can pee out some of those nitrogen-based waste products that we've created. So it's really simple. What does blood do? It transports. What does it transport? It transports things that we want to places where we want them to go, and things that we don't want to places where we want those things to go, so we can get rid of them. Transport. One of the things it includes here is temperature control, because blood also transports heat. Remember, all of the cells in our bodies produce heat, not just muscle cells. All of the cells in our body produce heat. If they are doing anything related to metabolism, heat is being created as a byproduct. So there's a lot of heat that's being created. So what we want to do is we want to get rid of some of that excess heat and take it to the outside world. And how do we get it to the outside world? All we have to do is get it to our skin. Well, how do we get heat that is produced, that's not even a word. How do we get heat that is produced deep inside of our body? How do we get that heat to our skin? All we got to do is transport it. And what transports things? Blood. So if the blood picks up some of that heat and it transports it to our skin, and then the heat goes from the blood to the skin, and then from the skin to the outside world, well, then we've gotten rid of some of that heat. Again, it's still just transporting. So what is blood made up of? Well, two major components in blood. There's a liquid component and there's a solid component. Those are the two basic components of blood. The liquid component is made up of what we call plasma, and that is around 55% of blood is made up of plasma. Sorry, about 55% of the blood is made up of plasma. And the solid parts we call formed elements. Those make up about 45% of our blood. Those are the solid parts. And notice here, when anyone asks me how much blood does a person have in their, does an adult have in their body, what I say is about 5 liters, because that's about true. Men tend to have 5 to 6 liters, women tend to have 4 to 5 liters. So overall, I think a good answer is 5 liters, because that's pretty much true in most people. Now, of course, it's going to vary. And when she's pregnant, that her blood volume is going to increase considerably, 30, 40% or more. But yeah, good average, 5 liters of blood. Because if we lose 3 of those 5 liters of blood without replacement, that's it. We would die. Lose 3 of the 5 liters of blood without replacing any of it, and that's it. No going back. So now let's take a look at these two components, plasma and formed elements. And if you look at plasma, it's made up of 91% water. Now, that number will vary slightly from book to book. Some will say 90% water, some will say 92% water. So about 91% water is a pretty good average. So we're going to go with that. So if plasma makes up 55% of your blood and about 91% of plasma is made up of water, that means about almost half of your blood is made up of water. It's a lot. And then you can see these other things that are in plasma. There's a bunch of proteins with albumin. Albumin is a huge protein. It is a carrier protein, helps to carry a lot of things around. And it is the most abundant of the plasma proteins. 57%, that's a lot. I don't think you need to know the exact numbers on that, but albumin is a good one to know because it is the single most abundant protein in our blood. And it is a big one, and it is a carrier protein. And then there's other solutes. Remember, a solute is a solid particle suspended in a liquid. And you can see some of these things in there. Waste products, gases. Okay, great. So then what are these formed elements they're talking about? It makes up the other 45%. Well, the main one are the erythrocytes. Now, if you know that erythro means red, and of course cyto is cell, then erythrocytes are red blood cells. These are the mature red blood cells. And look at the numbers per cubic millimeter. 4.2 to 6.2 million. That's a lot. There's a lot of red blood cells in our blood. In fact, there's so many red blood cells in our blood, it makes our blood appear to be red, which is why if we took out the red blood cells, then we pretty much just have plasma, which is a straw or clear colored liquid. The other formed elements are the white blood cells known as leukocytes. Well, you know, leuko means white and cyto means cells, so that makes sense. And then the other particles are called platelets, which are also known as thrombocytes, because thrombo means clot. Cyto means cell, so cells that clot. Unfortunately, platelets aren't actually cells, however. Platelets are parts of a cell. They are fragments of a cell, but they are active in the blood clotting process. And look how many there are. That's a big number. However, they're very, very small because they're not whole cells. They're just fragments of cells. The white blood cells are larger in size compared to red blood cells, but there's a lot of red blood cells. In fact, there's so many red blood cells in your blood, it makes the blood appear to be red. I may have mentioned that once or twice. Then what they've done for you here is they've broken down the white blood cells into the types of white blood cells. The neutrophil, which is sometimes referred to as a polymorphonucleated cell, polymorphonucleated, PMN, yes, polymorphonucleated leukocyte, or neutros, if you want to abbreviate it that way. I still call them neutrophils. Make up somewhere around 65% of all the white blood cells in your body. And we will see later on that these things are phagocytes. They can go around gobbling up a bunch of stuff, but they're most specific for destroying bacteria. Lymphocytes are the smallest of the white blood cells in size. They're still bigger than red blood cells, but they're the smallest in size, and they make up somewhere, this number is a little bit low. I'd say closer to like 30% of all the white blood cells in your body are lymphocytes. And they have a lot of different roles that they can take, and they can be phagocytes. They can gobble stuff up as well. And generally speaking, lymphocytes are more specific for viruses. Monocytes are big white blood cells, make up a small percentage, you see here. And they're going to become tissue specific. They're going to go to specific areas of the body and just hang out there, like the skin or the lungs or the spleen. And they're going to destroy things. You have a big kidney bean-shaped nucleus. You can always spot monocytes that way. And then the eosinophils make up around 2% of all the white blood cells in your body. That is pronounced eosinophil. You pronounce the E, then the O, then it's a sinophil. Eosinophil. And these are also phagocytes, which can gobble things up. And they are most specific for allergens and parasites. Eosinophils. The last one are the basophils. They are not phagocytes, and they make up less than 1% of all the white blood cells in the body. These are going to release histamine and heparin in the blood. Specifically in the blood, because there's other cells called mast cells that release histamine in the tissue. These release histamine in the blood, and histamine is going to, let me make sure I get this right. Histamine increases vasopermeability, which means it's going to allow for blood flow, or not blood flow, cells to move through the walls of the blood vessels to get to where they need to go. And heparin, you may have heard of this before. Heparin is going to have an effect on decreasing clotting. Now, I talked about platelets being involved in the clotting process. Heparin doesn't work on platelets, it works on other clotting factors. But platelets are one of the first things involved in forming clots. And then we have these other factors that come along and they help out in making the clots and strengthening the clots. And that's a good thing because we want to have clots. We do. Because if we get cut, we do not want to leak blood everywhere. So we want to be able to make clots. Not to mention our body's constantly going through these remodeling processes. So we have to get rid of old cells and replace new cells. That includes with blood vessels and blood vessel lining. So there's going to be disruption there. So of course, we're going to want to be able to create clots to stop that while we create new cells. But of course, some people can create too many clots, in which case we're going to want to stop that action. So people say, is it good to form clots? Well, yes and no. It's good to form clots when you need to. It's not good to form too many clots when you don't need them. Erythrocytes are red blood cells. Thrombocytes are platelets. Leukocytes are white blood cells. Thrombocyte is a platelet is a thrombocyte. Now, where do these come from? I'm going to jump ahead just a moment and show you this chart here. Because all of our blood cells, red blood cells, white blood cells, and the cells that are going to create platelets, all of these blood cells come from the bone marrow. All the blood cells in our body are made in that red bone marrow. And they all come from one progenitor cell, what you'll hear me refer to as the hematopoietic pluripotential stem cell. This guy right here. They just call him a hemocytoblast, but I still use the term hematopoietic pluripotential stem cell because this one cell can become any of these. All we have to do is tell it to. All we have to do is tell that hematopoietic pluripotential stem cell, cytoblast, to become a red blood cell. And once we tell that cell to become a red blood cell, then it starts down this pathway over here. And it starts to change. And it changes. And it changes until eventually becoming a red blood cell, an erythrocyte. If we want that cell to become a neutrophil, then it will start down this pathway. And then to the neutrophilic myelocyte pathway, until eventually becoming the neutrophil at the end. Now, some people do call neutrophils band cells, but the reality is a band cell is an immature neutrophil. It hasn't completed yet, hasn't completed the process. So you might hear that term as well. If we need platelets, if we need to make platelets, all we got to do is tell this cell, hey, we need to make platelets. It's going to go down this pathway, become a megakaryoblast or megakaryocyte, which is then going to start to break parts off. And those parts are going to become platelets. That's why I say a platelet is not a cell, it is a fragment of a cell. Notice there's no nucleus in there, no DNA. If we want to become a lymphocyte, well, you get the idea, right? Now, here's something that they don't explain to you that really needs to be explained a little bit, because I know when I was learning about these, I got confused. Because if all of these cells can come from this one stem cell, and these stem cells are found in our bone marrow, and we make 1 to 2 million red blood cells every second, that means 1 to 2 million of these are going to become red blood cells every second. Well, wait a minute. How many of these do we have to start off with? Because if we only have 10 million of these to start off with, well, then in 5 to 10 seconds, we're going to completely run out. So that doesn't make sense. Now, of course, we have more than 10 million, but how does that happen? I told you that if we need this cell to become a red blood cell, we just tell it to become a red blood cell, and it starts down this pathway and eventually, and eventually becomes that erythrocyte that we see way down there. However, this is important for big picture understanding. When we tell this stem cell right here, we need you to become a red blood cell, an erythrocyte, this hemocytoblast is going to say, okay, I got the message. Hold on, because first I'm going to make a copy of myself. Because now if I make a copy of myself, well, then the original one can go down that pathway and become a red blood cell. Plus I have a new one in its place waiting for the next message. Now that makes a lot more sense. So before he goes down that pathway and becomes that red blood cell or that neutrophil or that eosinophil or that lymphocyte or that cell becomes platelets, he's going to first make a copy of himself. Okay, so what clinical significance does that hold? Who cares? Well, let's consider this for a moment. Anytime a cell makes a copy of itself, it has to first copy the DNA that's in that cell. And of course, this is going to have a nucleus. It's going to have all the directions. You got to have directions on how to make white blood cells and red blood cells. So it's going to have a nucleus. It's going to have all that DNA. So the very first thing that cell is going to copy is all of that DNA. That's the first thing it's going to copy. And that's also the most expensive thing to copy. And when I say expensive, we're not talking about money. We're talking about energy. So it's going to require a lot of energy in order for this cell to, okay, make a copy of himself before the original then goes down that pathway and becomes a red blood cell. And then also, what did I tell you about cells and their DNA making copies and then having to make a copy from a copy and then having to make a copy from a copy of a copy, and then a copy from a copy of a copy of a copy? Where I said after a while, that DNA starts to get maybe unreadable. Maybe there's mistakes that occur, which means the next cell that forms from that DNA is going to be different. It's going to change. And what do we call it when cells change? We call that cancer. So when someone asks me, Dr. Sturgeon, why is it there's so much bone marrow cancer occurring in elderly patients? I don't understand. I don't understand that, generally speaking, the most common cancer in elderly patients is skin cancer, followed by bone marrow cancer. Are they all getting that many x-rays or exposure to radiation or something? No. It's because over the lifetime, these stem cells are making copies of copies of copies of copies of themselves. Because before they go down that pathway and become a red blood cell, it first has to make a copy of itself. And that makes a lot more sense, that over a lifetime, there's going to be more mistakes made. Remember, skin cells are constantly dividing and being pushed to the surface. So they're constantly making copies of themselves. So yeah, that would make a lot of sense that it's the most common cancer, generally speaking, in elderly patients over time. But why would bone marrow cancer be the second most common? This is the reason why. So it's important, big picture understanding is what is happening in our bone marrow. We have all of these stem cells. They call them hemocytoblasts. I call them hematopoietic pluripotential stem cells. That can become any cell we need it to become. And just think of the numbers. If we make 1 to 2 million red blood cells every single second, 1 to 2 million. Some books will say up to 5 million red blood cells every second. I think that's a little on the high side. I like to go with the 1 to 2 million red blood cells every second. Then we must be making a lot of these hemocytoblasts, or we must be copying an awful lot of them, because you'll notice there's nothing above them. They don't come from anywhere else. So they have to make copies of themselves first before that original cell starts down any of these pathways and becomes these cells that we see down here. Now, a mature red blood cell does not have a nucleus. But how can that be? Because it started out as a cell with a nucleus. And even if we look here at the proerythroblast and down to the basophilic erythroblast, the polychromatic erythroblast, nucleus, nucleus, nucleus. But then we see the reticulocyte, and it's starting to look like that nucleus is fading. It is. It's breaking up into smaller particles. And as those blood cells go through the spleen, that's one of the jobs of the spleen, is to take out those extra particles that used to be a nucleus. Why don't we want a nucleus in a red blood cell? Because remember, a red blood cell is a bus. And buses carry passengers. And our red blood cell bus also is going to carry passengers. But what passengers is it going to carry? It's going to carry oxygen. So what we want to do is we want to create as many seats on this bus as possible. Just like any bus, you want to have a whole lot of seats. The more seats you have, the more passengers you can carry. If this red blood cell had a nucleus, well, there wouldn't be room for as many seats. If this red blood cell had mitochondria, there wouldn't be room for as many seats. So these cells, these red blood cells, they're not going to have that, because we want to pack it full of seats. What do we want to put in those seats? Oxygen. That's our passenger. Remember, those seats are called hemoglobin. Capital H, small b, hemoglobin. And I said before, there's a frame in each seat. And you need that frame in order to hold on to oxygen in order for the seat to work. And we call that frame iron. I won't put the plus signs, I'll just call it Fe, iron. So that red blood cell has got to get rid of its nucleus to make room so it has enough seats to put as many passengers, as many oxygen passengers as we possibly can fit. All these white blood cells have nucleus, 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 nucleus. And then again, the platelet is not a cell. It is a fragment. And this is actually a really good diagram of the megakaryocyte as it breaks apart. And each of these little broken parts become platelets. So they're much smaller. Oops, I think it's the wrong size. Erythrocytes, red blood cells, mature red blood cells, are these biconcave discs. They sort of look like a donut that isn't punched through all the way. And the reason they have that round shape is because hemoglobin is a round-shaped molecule. So this thing is so packed full of round-shaped molecules, it makes that red blood cell have this round shape to it. But it's still really flexible because it has to be. The blood vessels that branch off into the smallest, tiniest blood vessels called capillaries are so small that red blood cells have to go through single file. And in fact, even then they have to be flexible to get through the capillaries. So these are flexible biconcave discs that are going to be packed full of hemoglobin so that they can be packed full of oxygen. We make 1 to 2 million red blood cells every second. So many red blood cells in our blood, it makes our blood appear to be red. Red blood cells play a critical role in the transport of oxygen. Notice I didn't say carbon dioxide. Yes, they can and do carry carbon dioxide. That is true. However, most carbon dioxide that we create is not carried by red blood cells. Most carbon dioxide we create is converted to bicarbonate and is carried in the blood as bicarbonate, HCO3-, which is important because that is the most powerful buffer that we have in our blood. So it helps to keep our blood from becoming too acidic. So carbon dioxide is useful. We can convert it to bicarbonate, HCO3-. As it travels to the lungs, it's converted back to carbon dioxide, and then we can just breathe it out. One hemoglobin molecule binds 4 oxygen molecules, 4 O2s, not oxygen atoms, oxygen molecules. And we call that oxyhemoglobin, just because it sounds cool. Oxygen sitting in their seat. Yes, it can bind to carbon dioxide, carbaminohemoglobin, but that doesn't sound as cool. Now, here's a little bit of a problem. Anemia does not mean a low red blood cell count. That is not true. Anemia is a sign of a disease. Anemia is a sign of a disease. Just like a fever is a sign of a disease. Not every person who has a fever has yellow fever. Not every person who has Rocky Mountain spotted fever, no, not every person who has a fever has Rocky Mountain spotted fever. Not every person who has a fever has Crimean Congo hemorrhagic fever. A fever is a sign of a disease. Although, yes, it can be found in the name of some diseases, the word fever is a sign of a disease. Anemia is a sign of a disease. A person who has sickle cell anemia can have just as many red blood cells. Many of them are just shaped wrong. A person can have a microcytic anemia where their red blood cells are particularly small, not going to do their job as well, but they can still have the same number of red blood cells. So this is something where people get confused a lot. Most of the time I hear people say, I have anemia, and I have to ask, well, what does that mean? And they usually say something like, well, that means I have low iron. No, that's just one type of anemia. That's an iron deficiency anemia, which just means they just need more iron. Most of the time, women under 40, if they have an iron deficiency anemia, most of the time it's the result of not getting enough iron in their diet. I know people will say, oh, it's because women menstruate and they lose blood. Oh no, the body takes that into consideration. Most of the time it's because they're just not getting enough in their diet. This is why I say eat red meat. Don't be afraid of red meat. It's a good thing. Lean red meat, of course, because we want to minimize the fat. Also, the spinach. Get those salads and put that spinach on it. How close am I? Okay, I'm pretty close. Not quite as close as I want it to be, but pretty close. Oh no, I won't want to go there. Oh yeah, I'm going to stop for now. I was right. So it's a vocabulary term, and you would think that, why is he spending so much time on a vocabulary term? Because it's an important one, and it's a one that people often don't understand, which is why we see it in slides like this, where somebody has written that anemia means it's a low blood count or a low red blood cell count, and that just isn't the case. It does indicate that there's some problem with the oxygen delivery system, but it doesn't necessarily mean they don't have enough red blood cells. It could just be the red blood cells are wrong. You really need to make sure you have your name up on the screen, because I don't know who you are otherwise. I can't see your face. So I might accidentally mark you absent or intentionally mark you absent. I'm not going to intentionally mark you absent. But please make sure you have your actual name up on the screen. Although I think I've marked everybody here who's here. So does anyone have any questions about anemia? There's a type of anemia, or classification, I should say, of anemia called a hemolytic anemia. Lytic, like lysis, means to break apart. So red blood cells break apart. And there is one called glucose 6-phosphate dehydrogenase deficiency, also known as G6PD. If you've not heard of glucose 6-phosphate dehydrogenase deficiency, you will. It is the most common inherited hemolytic disorder, which means someone you know is going to have a son born with this, if you don't already know someone. Their red blood cells are running on the most basic minimal amount of energy. And if anything comes in that could stress their red blood cells, require their red blood cells to create more energy, the red blood cells just break apart. And if red blood cells, which are buses carrying oxygen, break apart, well, then we don't have as many buses bringing oxygen around. Now that could be a problem. And there is a list of things that people with G6PD need to avoid, including everything from fava beans, you'll see that one usually somewhere on a list, to mothballs and malarial medications. So there's lots of different medications on that list, but it's usually a boy, because this is an X-linked inherited disorder. So typically women, because they have 2 X chromosomes, if they don't have the directions for this enzyme on one of the chromosomes, well, they still have another chromosome, so it's probably there. So they're less likely to have it. But because boys have 1 X chromosome, 1 Y chromosome, they're missing the directions on how to make glucose 6-phosphate dehydrogenase. And that is going to cause that issue when their red blood cells need a little more energy. So that creates a hemolytic disorder. If you've not yet heard of it, you will. Okay. Questions about blood so far?
I do, because I
Yes.
heard about the fava beans before. What does that do by eating a fava bean? Like, how does that affect the patient?
I don't know the exact stress that it causes on a red blood cell. I don't know the biochemistry of the fava bean that causes the stressor on the red blood cell, but that's what it does. For some reason, it affects the red blood cells, requiring the red blood cells to utilize more energy. They run out of energy and they break apart.
Okay.
I've never even bothered to look it up. I don't know why. I guess I just never cared. But yeah, I don't know the biochemistry of the fava bean to know why that happens, or the ingredient in the fava, that particular bean, that causes that to occur. I'll look it up now. I'll look it up on the break, I should say. Thanks for yet another question that I can't answer. I appreciate that. Especially this is going on YouTube.
I'm not doing it on
the,
purpose.
everyone on the planet will say, God, this guy doesn't know anything. Everybody knows about the fava beans. That's okay. I don't know everything. There's a lot to know. I don't know everything. All right. Well, we should take a lunch break. Come back at 1. Make sure you come back at 1 so I can mark you as being present as we go into the second part of the course. We'll continue with some blood stuff though. But I got through some of the main things I wanted to let you know about. All right, I will see you at 1 o'clock. Take a break for this. So why is it when you go from a sitting position or a lying position and you suddenly stand up and then you sort of get that dizzy feeling for a moment? Why does that happen? Or you see stars for a moment? Well, there's definitely a change in blood flow from a seating or lying to a standing position. And we have pressure sensing cells right in our carotid bifurcation, where the carotid arteries come up. And those pressure sensing cells are going to sense the pressure that's going up to the head. And that pressure is going to be determined by things like your position in the world, whether you're lying flat or sitting or standing, obviously, if you're bent over. And then it's also going to be dependent upon blood flow going back up, back to the heart, which can help determine how much blood flow is going to get pumped back out again. So when you suddenly change that position, the change in the amount of blood going up through those carotid arteries is going to be altered. And most of the time, the body is going to compensate for that. It's going to send a message to the heart that says, don't send as much blood right now, or send more blood right now. But there's a moment where all these systems have to make those changes, have to adjust for that. So the amount of blood that's going up to the brain is going to be adjusted. Oftentimes, if it is lower, the person is going to feel dizzy or lightheaded. In some cases, they will actually pass out. They bend over to tie their shoes and then suddenly stand up. Most of us would just get dizzy for a moment or see stars for a moment. But for these patients, they would actually pass out. And it's the reason is, yes, it is blood flow based, how much blood is going up to the brain. And their body can't compensate quickly enough. Now, the nice thing about lying down is that it's easy to regulate blood pressure throughout the body if a person is lying down, because they don't have to fight all these different directions of pumping blood. It's very easy. It's straight horizontal. So imagine if a person bent over, tied their shoes, suddenly stood up, and then passed out. Then they would be lying flat, which would actually help with the distribution of blood flow. So passing out could actually be helpful. They could utilize gravity to put the body into a horizontal position. Just don't tie your shoes near the Grand Canyon. Pass out, that wouldn't be good. We'll talk a little bit more about that in the chapters to come. I don't know how much we're going to get into the cardiovascular system today, but In the chapters to come, we will. In the cardiovascular system, we definitely will. Okay, so we're talking about blood and how blood transports things. And it's going to transport things that we need to places where they need to go, and things that we don't need to places where we can take them to get rid of them, whether it's temperature, like heat, or whether it's waste products that are created. We found out that blood is made up of two main components, liquid and formed elements. The liquid part we call plasma. About 91% of that is actually water, and the formed elements are the red blood cells, the white blood cells, and the platelets. And we then found out that all of those formed elements are made in our bone marrow, specifically our red bone marrow. And we found that all of those cells come from one progenitor cell. One stem cell is capable of creating any one of those cells. All we have to do is tell it to become any one of those cells. That's all. And as soon as we tell it to become any one of those cells, it says, okay, hold on just a minute. I'm going to make a copy of myself. I mean, it doesn't work. That's the idea behind it. The big picture idea. So that now that cell that was one becomes two. Now the original one can go down the pathway, become the blood cell it needs to become. And then the other one could just wait until the next order, whatever it needs to become. Remember I said we make between 1 to 2 million red blood cells every second, and that's a number that should surprise people. You should think that's a lot, because it is. I can't imagine doing 1 to 2 million of anything in a second. So it should be a bit unimaginable, I think, for most people. Okay, let's kind of pick up. We talked about how red blood cells are the buses that carry blood throughout the body. Carry oxygen throughout the body. Let me try that again. Red blood cells are the buses that carry oxygen throughout the body. And that these red blood cells have a biconcave disc shape to them, and that they are flexible. They have that shape because the hemoglobin molecule, which is the seat on the bus, is a round, or they call it a globe-shaped molecule. And because they're all round molecules packed inside of this flexible membrane, it causes the whole red blood cell to then take on that shape, that round shape. So imagine what would happen, actually, you know what, let me make them in, I have them in green before, yeah, let me make them in green. So if we have a whole bunch of round molecules, and we bunch them together into a flexible membrane, because they're round, they're sort of going to take on this shape, this round shape. So what we end up with is a red blood cell that has that biconcave shape. If you look at it from the side, biconcave disc, or if you look at it from the top, it's round with a indented center. The reason for that is because of all these round molecules of hemoglobin in here. Imagine what would happen if that hemoglobin had a stick shape. They would probably stack on top of one another, something like that. And since that membrane on the red blood cell is flexible, it's going to take on that shape, which is exactly what we see in what disorder?
G6PD.
No.
Sickle cell.
G6PD.
Sickle cell.
Sickle cell. Yeah. G6PD, we're going to have red blood cells that look like this, torn apart. These are stick-shaped. And the reason for that, the reason the red blood cell has a stick shape or a sickle shape is because the hemoglobin molecule is wrong. The hemoglobin molecule is made up of 4 different components, 4 chains, 2 alpha and 2 beta in adult hemoglobin, alpha 1, alpha 2, beta 1, beta 2. And it's the beta chain that's wrong. And because the beta chain is wrong, it causes the whole hemoglobin molecule to take on a stick shape. And that's all because of one little error of valine instead of a glutamine, or a valine instead of a glutamine on chromosome 11. One little error, one little mistake in that DNA strand causes that beta chain of the hemoglobin to be wrong, which causes the hemoglobin to be wrong, make that stick shape, which then packed all together in a red blood cell makes the red blood cell wrong. Now, why is that a problem? Well, because as red blood cells go through the tiny little capillaries, they have to go through single file. And even then, they have to be squishable to a certain extent. They have to be flexible enough to get through. If these sticks come along and they're not flexible, then what happens? Blood flow stops. Which means all of the cells that are waiting down here for oxygen are not getting oxygen. If they're not getting oxygen, are they going to make a lot of energy or less energy?
Less.
And are these patients going to, or what's one of these things these patients are going to complain of then?
Weakness.
Weakness.
Fatigue.
Weakness, fatigue. And then eventually these cells are going to die. What happens when cells, especially like muscle cells, die? Do they like that? No.
Atrophy.
They're going to get angry. How are they going to let you know that they're dying? We are dying. How are they going to get your attention?
You might have physical symptoms.
Yeah. How about like pain?
What about like atrophy for muscle, like if your muscle cells?
Eventually, yes. But this is most immediate. That's going to hurt a lot. Then, of course, if we're talking about like muscle pain, it's going to hurt a lot. And then we're going to end up with other problems. Rhabdomyolysis is what it's called, breakdown of skeletal muscle. That's going to release some bad things into the blood. And those bad things are going to make their way to the kidneys, which are going to do bad things to the kidneys. So when skeletal muscle dies, rhabdomyolysis, bad things happen to the kidneys. Affects the kidneys, not good. So something to just kind of keep in mind. But this is why sickle cell anemia is not a great thing. But if it's not a great thing, why do people still have it? It doesn't make any sense. If this is a bad trait, why do people still have it today? Because bad traits die out, good traits stick around. So people with normal red blood cells, that's a good trait. People who make sickle cells, that's a bad trait. And people with bad traits, well, those traits die off over time. Good traits become more prevalent. This is what we call evolution. Now, the only possible explanation is that having sickled cells is a good trait. That can't be right. That cannot be right. How can having sickle cells be a good trait if it can cause all those bad things to happen? That doesn't make any sense. Unless there's a parasite that can get into the body and make its way into the red blood cell. Because if this parasite gets into the body and makes its way into the red blood cell, the rest of the body doesn't even know it's there. The immune system doesn't know it's there. It's literally hiding. And while it is hiding, it's growing. And then eventually, it'll break its way out of that red blood cell, which means that red blood cell is now useless. Now imagine this is just one parasite coming into the body. Imagine millions of these parasites all coming in at once, hundreds of thousands, millions, all at once. And all of these parasites going into the red blood cells all at once. And then all those red blood cells dying, broken apart all at once. That's going to cause some serious problems in that patient, especially if it's a young patient, like a 5-year-old child. Because then that 5-year-old child's going to die. And when that 5-year-old child dies, that 5-year-old child doesn't get the opportunity to reproduce. In other words, to have children, because they're only 5, but they're dead. So now they cannot make babies. So they don't pass on those genes. Well, what if, for some reason, having a sickled cell toughens that membrane, and now that parasite cannot get in to begin with? And now the body just comes along and destroys us. Says, well, you don't belong here. I'm going to destroy you. And now this person was 5 years old, but then they survived to be 6 years old, and 7 and 9 and 15 and 25. And now they have children, which means they pass on their genetic traits. In this area where this parasite is prevalent, where this parasite exists in large numbers, having normal red blood cells is actually worse. It's actually a bad trait to have normal red blood cells in this environment. It's actually a good trait to have sickled red blood cells in this environment, at least when you're considering the person's going to get to the age where they'll be old enough to reproduce and have more children, have more offspring, pass on their genetics. That young baby who died at 5 won't. Which means the population of people with normal red blood cells in this area is going to reduce. There's going to be less and less of these people with normal red blood cells, and more of these people with sickled red blood cells. So what parasite would do such a thing? I think that's right. Plasmodium falciparum, or Plasmodium vivax, or Plasmodium malariae. This is the parasite that causes malaria. So in environments, and of course, malaria is spread by the bite of a mosquito. So in these areas where these mosquitoes are prevalent, where the parasite is prevalent, more kids with these types of red blood cells are going to die. So they're not going to pass on their genetic code. More kids with this type of red blood cells actually going to live and get old enough to have children and pass on their genetic code. So areas that are endemic for malaria, we see an increase in those types of sickled red blood cells. So it actually was, or is, I should say, a good trait to a certain extent. Now, does it cause those things we just talked about long-term? Yes, absolutely. Is that bad? Absolutely. But does the person at least live long enough to pass on their genetic code? Yep. Rather than going to a coma and dying when they're 5 years old. So as this number increases, well, they just increase. That genetic code, which just keeps going and going, which is why there's such a high number of people with that abnormality. And actually, there tends to also be the similar effect with G6PD, which is why we find it in the same regions. People from those same regions tend to have either the sickle cell trait or G6PD. Both are considered a type of defense of sorts against infection with this parasite. So if somebody asks you, is having sickle cell disease a good thing? You could easily say no. But they could ask you, was it ever a good thing? Or could it ever be a good thing? Well, then, yeah, actually, strangely enough, it could. Okay. Mature red blood cells are called erythrocytes. The formation of red blood cells is called erythropoiesis. They start off from that hematopoietic pluripotential stem cell and then becoming whatever it needs to become. Remember, we make 1 to 2 million red blood cells every second. That's a lot. There's going to be differences in the way that our body is able to deliver oxygen, depending upon something that's a little bit unique, a little bit unusual, I should say, not unique, a little unusual. And that is if you consider where we are compared to the ocean. In other words, if we're at sea level, we have the ability to deliver oxygen based on that. But the higher we go in altitude, that's going to change because the pressure in higher altitudes changes as compared to our bodies, as our bodies are created to withstand things like sea level. So when there's sea level pressure, our bodies are functioning pretty normally. But as we change that, that's going to have an effect on how our bodies function, including things like delivering oxygen around. Where the body might then say, well, if we're not delivering oxygen around, we should probably make some more red blood cells. which is exactly what happens. There is a sensing area in the parts of the kidneys that we'll talk about later on. We'll talk about them later on. The juxtaglomerular areas, these cells that can react to different pressures in the body. And there will be a hormone that is released called erythropoietin. There. And erythropoietin will go to the bone marrow and tell the bone marrow, make more red blood cells and take the ones that you've already started to make. Remember, they go down that pathway and speed up the process. In other words, get more red blood cells out into the blood. Other things can cause this as well, like being born. When that baby is going through that traumatic process of being born, that could trigger the release of erythropoietin, which causes an increased amount of red blood cells to suddenly be produced, which we can also see a rapid destruction of red blood cells, which means some of those components in the red blood cells get broken down, but the liver cannot keep up with conjugating some of those things like bilirubin. So the unconjugated bilirubin ends up getting stuck in the skin. That's where the body's going to put it. Doesn't know what else to do with it, which is going to cause the baby to look yellow. We call that physiologic jaundice of the newborn. Might cause a buildup in unconjugated bilirubin in their conjunctiva, which is what we call scleral icterus, although it should be called conjunctival icterus because that's where the bilirubin is. But it can also increase the amount of unconjugated bilirubin in their brain, causing something we call kernicterus. Again, mental retardation. That's not good. All we have to do, however, is get these kids to pee out that unconjugated bilirubin, and they'll be fine. So once again, we put somebody underneath a special blue UV light, which basically makes unconjugated bilirubin water soluble, so they pee it out. In some cases, if the levels are low, the doctor will just say, take the baby out into the sun. But that's why that happens. Red blood cells have a lifespan of about 120 days. Well, they certainly can't make any repairs to themselves because in order to make a repair to yourself, you have to have an owner's manual with directions. And because a red blood cell, mature red blood cell, does not have a nucleus, there's no DNA, so they're not going to be able to make any repairs. So it has a lifespan of about 120 days. That's okay. We make 1 to 2 million every second. And then the hemoglobin gets broken down into these components, including that one that I just mentioned, bilirubin. And some of these are easily going to be recycled. Bilirubin gets conjugated in the liver, which is just a fancy way of saying gets joined up with his buddy with the help of something called UDP, glucuronal transferase, gets joined up. And then that bilirubin, that conjugated bilirubin, is moved on to create stuff like bile, that thick, yellow, bitter tasting stuff that you throw up after you finish throwing up everything else. That is the stuff that is used to emulsify fats, which is a fancy way of saying breaks down fats. So you see, we take that from here and we put it in there. This is also why if you get some kind of injury under the skin, initially there's redness and swelling, but then when the fluid leaves and the swelling goes down, you got things stuck there, like red blood cells that get stuck there. And then they get broken down. And you start to see the color changes in the skin from all these different particles that have been broken down in these cells that have now been destroyed. And one of the last ones you see is that unconjugated bilirubin sitting there in the skin, which is why the skin looks a yellowish color. It might be itchy even, because unconjugated bilirubin tends to do that. What the heck is that? Oh, I know what that is. That is a neutrophil. Now, how could I possibly know that's a neutrophil? Well, because I told you earlier, one of the other names for a neutrophil is a PMN, polymorphonucleated leukocyte. Poly means much or many. Morpho means shape, like morphology, shape. And nucleated means nucleus. So the nucleus of a neutrophil has a lot of different shapes to it. Polymorphonucleated leukocyte. That is a type of white blood cell. That is a type of white blood cell called a granulocyte. I'm going to get into a little bit of immunology here just for fun. So here we go. When these were first discovered, what they found were these cells and one thing they noticed about these cells is that some of them had what looked like grains of sand or something inside of their cytoplasm. And some of the white blood cells they found did not have these little things that looked like grains of sand inside of their cytoplasm. So what do you call cells that have a bunch of little granules floating around in them? Well, let's not make it too difficult. We call them granulocytes. Cells with a bunch of granules floating around in them. So what do we call the ones that don't have granules in them? We call them agranulocytes, because remember, a, just like and, means without or not. So when they were first looking at these and they wanted to classify them, they said, well, some of these have a bunch of little granules in them, some of them do not. So we're going to put them in two basic categories, granulocytes and agranulocytes. And the first one that we talked about already a little bit are the neutrophils. This is the most prevalent of the white blood cells. Again, about 65% of all white blood cells in your body are neutrophils, sometimes called PMNs, polymorphonucleated leukocytes. I'll just put that in parentheses, because their nucleus has a bunch of different shapes to it. Neutrophils are going to be phagocytes, where they can go around gobbling up stuff and although they can gobble up a lot of garbage, debris, and stuff, they're most specific for gobbling up bacteria. Which means If there is a bacterial infection, the body's going to say, we should probably get more neutrophils over there. So go ahead and get some neutrophils. Oh, we don't have enough? Well, why don't we make some more neutrophils and get them over there to destroy all this bacteria? Pretty smart, really. This one I talked about a little bit. Oops. Eosinophils is another type of a granulocyte. Eosinophils make up about 2% of all the white blood cells in your body. Eosinophils are also phagocytes. They can gobble up stuff, but they are most specific for allergens and parasites. And then the last one in this group are the basophils. And they make up less than 1% of all the white blood cells in the body. These are the ones that release histamine and heparin in the blood, or histamine and heparin in the blood. They are not phagocytes. We do not go around gobbling things up. Okay. Granulocytes. The way I always, initially, I always remember them because I just thought of Ben. Ben are the granulocytes, B-E-N, because Neb isn't a name. Ben, basophils, eosinophils, and neutrophils. Those are the ones with the granules. So then what are these ones without granules? Well, lymphocytes, which make up about 30% of all the white blood cells in the body. They are the smallest white blood cells. Also, phagocytes can go around gobbling things up. Most specific for viruses. Okay, so let's take this little bit of information that we have right here so far, and let's consider something. Let's consider a patient who has pneumonia, and they've come into the hospital with pneumonia. So we are going to assume it's community-acquired pneumonia, because it most likely is. And if it is community-acquired pneumonia, then it's probably the result of a streptococcal infection, a bacterial infection. So we're just going to automatically start this patient on a broad-spectrum antibiotic. But then we're going to do something else. We're going to take the patient's blood. And when we take their blood, we are going to run a CBC with a diff. CBC stands for complete blood cell count. But we don't want to know just how many of all their blood cells they have. We want to know the differential. In other words, I just don't want to know how many white blood cells they have. I want to know how many neutrophils, how many eosinophils, how many lymphocytes. I want to know all of these cells, because What if this patient has only a slightly higher than normal neutrophil count, but has a really high eosinophil count? Then what's causing this pneumonia? If it was bacterial, I would expect the neutrophil count to be really high and everything else to be normal or even low. But in this case, neutrophils only a little bit high, but eosinophils are off the chart. That tells me this person has a pneumonia, but it's not being caused by a bacterial infection. It's either the result of an allergic reaction to something or parasites. Or what if I check and I find out the lymphocytes are way off the chart? I don't know what that is. If lymphocytes are way off the chart, then this is a virus that's causing the pneumonia. Then why do I have them on an antibiotic? There's no need for an antibiotic. Antibiotics treat bacterial infections, not viral infections. I'm going to have to switch to amantadine, something antiviral for this patient. This is why that patient comes in with pneumonia. We assume it's community-acquired pneumonia because it probably is, which means we assume it's bacterial as an infection because it probably is, but we're still going to draw their blood. And we're going to draw their blood because we're going to look at how many white blood cells they have and which type are highest, because that's going to give us some information. Complete blood cell count with a differential, meaning specifically the differential is how many neutrophils, how many lymphocytes, rather than just how many white blood cells. So knowing that neutrophils are most specific for bacterial infections or lymphocytes are most specific for viral infections, that actually gives you a lot of information. Now, when you look at that lab result, some of those will make a little more sense to you, that those white blood cells would be a little bit high in that infection, that bacterial infection, for instance. It makes sense to you why we would draw their blood. However, I will tell you this, we are not done. Oh no. Oh no. Because we're still talking about lymphocytes. So let's talk about lymphocytes. Because lymphocytes can become T cells, or lymphocytes can become B cells. Staying in the bone marrow, they become B cells. If they go to the thymus, they become T cells. And there are different types of T cells that lymphocytes can become, including the helper T cell, also known as a CD4 cell, this little plus sign. Suppressor T cell, also known as a CD8 cell. Natural killer cell, also known as an NK cell. Natural killer cell. Cytotoxic T cell. Okay, so why do you need to know that lymphocytes can become T cells or B cells? And why do you need to know that lymphocytes that become T cells can become helper T cells, also known as CD4 cells. What is the significance of helper T cells? Helper T cells are the target of HIV, human immunodeficiency virus. Helper T cells are the target of the human immunodeficiency virus. So let's take one of our helper T cells here and see what that means. I'm going to be simplifying this just a bit, to say the least. So we have the virus, human immunodeficiency virus here as a little purple star, or sort of a star. Now, of course, remember, viruses are much smaller than the cell. So the virus is going to enter the cell. So why would a virus want to enter a cell? Well, the same reason I want to sneak into a bakery in the middle of the night when they're closed and sneak all my recipes into their recipe book and get out before they come back. Because then when they come in the morning to start making the recipes, they open up the recipe book. What do they see? They see my recipes. So what do? They follow my recipes. They use their sugar, their milk, their chocolate, their ovens, their workforce. They use all of their stuff, but they make what I want them to make. So here, we start the production of more and more and more of these viruses. And as they leave, each one of those viruses goes into another helper T cell and does the same thing over again. So what happens? Oops. No, that's what I wanted. What happens to this helper T cell? It dies. And each one of these goes into a new helper T cell to do that whole process again. And so one goes in, 100 come out. And each of those goes on to infect another helper T cell. So over time, the body's going to start running out of helper T cells. So it's going to try and make more, which is really just helping out the cause here. Because remember, these are all going to get infected. And the body puts up a good fight and continues to try to keep up. But eventually, the helper T cell count goes lower and lower and lower and lower. And the patient ends up with an opportunistic infection, like Pneumocystis jirovecii. And then their helper T cell count goes below 200 cells per cubic, per cubic millimeter. When those two criteria are met, now the patient has the disease. Acquired immunodeficiency syndrome. Those are the two main things that must be met. Opportunistic infection, which would usually come first, and then their helper T cell count goes below 200 cells per cubic mole, 200 cells per cubic millimeter, where it's usually around 500 to 1500. When those two criteria are met, then the patient has the disease AIDS. Not full-blown AIDS. There's no such thing as full-blown AIDS. That's just an exaggeration, just like saying someone is full-blown pregnant. We know what that means when we see her and she's like, whoa, way out to there, ready to go any minute. We say, wow, she is really pregnant. Now, she's pregnant. It's just an exaggeration. So there's no such thing as full-blown AIDS. That's just an exaggeration. They have either met these qualifications or they have not. If they only met one of the qualifications, then they're still just HIV positive. But when those two are met, then we say the patient has the disease AIDS. So that's why. Now, think about this. Back a few moments ago, I talked about lymphocytes. Lymphocytes are agranulocytes. They're the smallest of the white blood cells. They are most specific for destroying viruses. And a helper T cell is a type of a lymphocyte. So it should be involved in destroying viruses. But in this case, the virus destroys it. There's some pretty amazing irony there, I think. I did say that a lymphocyte can become a T cell or a B cell. So what does a B cell do? Well, again, I'm going to go into simplification mode because the immune system can get a bit complicated. But, okay, here we have something that has entered our body. It looks like this. Uh-oh. I hope that's not bad news. Oh, okay. We have these parts of our immune system, these white blood cells, who will stumble across this and say, wait a minute, you don't look familiar at all. You do not belong here. You need to die. And that's what this cell will do. This cell will gobble this up and destroy it. But he will also mention this to that B cell. And this is like one of the main things a B cell can do. It will say, I found this guy. He didn't belong. And this is what he looked like. It'll present these antigens to the B cell and say, I found this guy. He doesn't belong here. I killed him. And by the way, this is what he looked like. Oh, and one more thing. I found out when I destroyed him that this potion worked the best. Formula 606. I don't know. I'm just putting a potion name to it. This is the potion that destroyed him and worked the best. Oops. I found a guy. He didn't belong here. I killed him. He looked like this. And by the way, this is what worked the best to kill him. So the B cell is going to take this information and become a plasma cell. Okay, big deal. What the heck is a plasma cell? What do they do? Oh, it is a big deal because I'll tell you what they do. Plasma cells, they make antibodies. Antibodies look like the letter Y. Okay, plasma cells make antibodies. Antibodies look like the letter Y. What's the big deal with that? Oh, it is a big deal. So if we look at what this intruder looked like, he has antigens that come off of him that have a very unique shape to them. These antigens that are sticking out are very unique in their shape. The antibodies that are created in this Y shape are designed to fit this shape, the Y shape to them. They're designed to fit into those antigens like a key fits into a lock. What that means is now this person's body is making these antibodies to this foreign guy. Remember, that foreign guy got destroyed simply because the big guy happened to stumble across him. What if the next time he doesn't stumble across him fast enough? Well, then he could start an infection. Not now, however, because now as soon as that guy who doesn't belong enters our body the next time, these antibodies are going to snap onto him like magnets. And they're going to light him up like neon and say, we got an intruder here. He doesn't belong. Come and kill him. Oh, and by the way, this right here works the best to kill him. And that's just some of what the antibodies are doing. That's pretty cool. Now, there's a problem, however. I said those antibodies fit into that antigen, that foreign antigen, like a key fits into a lock. What if the next time that guy comes in, that antigen is changed just a little bit? That means those antibodies won't lock onto them. Which means they're no longer going to be useful against that particular guy when he looks like that. So we're going to have to go through this process again. And that's exactly what happens with things like viruses that mutate, like influenza. Every year becomes a little bit different. Changes just that little bit. So the antibodies from last year, they're not going to work. That lock has changed just the slightest bit, but it's changed enough. So we have to come up with a new vaccine with new antibodies. How do we do that? How do we get a vaccine anyway? And again, big picture here, going to simplify it a bit. Let's consider this guy for just a moment, this bad guy with these antigens sticking out of him. If this is a virus, we know that a virus has either a DNA or RNA inside of it. So we'll go with a DNA virus, like hepatitis B is a DNA virus, for instance. So what is the dangerous part about a virus? The dangerous part about a virus are the directions. So what if we could take this virus with this dangerous DNA? What if we did something where we got rid of the dangerous DNA? Now it's just an empty shell. However, this guy doesn't know it's just an empty shell. He thinks this is an intruder. So he's going to go through that process, which means the plasma cell is going to make antibodies for it. All we got to do is get rid of that dangerous stuff on the inside. We have an empty shell. Again, this is sort of a simplified overview of it, but that's basically what we're doing. And if he changes a little bit like that flu does, well, then we have to do it again. If it changes a little bit like that flu does, we have to do it again. If it changes a little bit like that flu does, we have to do it again. So now you're thinking, well, wait a minute, Dr. Sturgeon, I've got this all figured out. Because if we have something like the HIV virus, which I'm making look sort of like a stop sign. If we have the HIV virus, and the HIV virus has these antigens sticking out of it, why don't we just make a vaccine the same way? And that's a really good question. The problem, however, with, I said HIV virus, I meant to just say HIV, human immunodeficiency virus. The problem with human immunodeficiency virus is that it looks like this right now. But then it looks like this. 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 It's the fastest mutating virus we know. We cannot make a vaccine because it changes way too fast. And remember, those antibodies have to fit like a key in a lock. So if you just installed a new lock on your front door and you said, oh, I better make extra keys, and you go down to Home Depot and you make some extra keys and you come back, by the time you get back, there's a new lock on the door.
Dr. Sturgis, wait a minute. Now you said that don't make a vaccine for the HIV because it changes so much. Isn't that the same thing with the flu? Because there's different strains of the flu and now COVID.
What I said about the flu is that it looks like this year. The next year, it looks like this. The next year, it looks like this.
Okay, I missed that part. I kind of came in like,
Sorry.
wait a minute. Yeah, I'm sorry.
What I want to make clear is when I was doing with the HIV is that it looks like this. Then it looks like this. Then it looks like this.
Right.
then it looks like this. It happens so rapidly, there's no way to make a vaccine quickly enough.
Got it. Sorry.
But,
Emulate.
but, Dr. Sturgeon, you say, what if there's one, well, that's not the right color I wanted at all. What if there's one little antigen that never changes? What if that one always stays the same?
Yeah, like the base.
Couldn't we use that as a target and use that one to make a vaccine from? That's a really good question. The problem is, how big is a virus? Well, viruses are small. Viruses are much smaller than bacteria. Viruses are 3 zeros smaller than bacteria. Not 3 times smaller, 3 zeros smaller. So the only way to see a virus is on an electron microscope. And what we're talking about here is we're talking about things that would be like the size of a hair off of something like your arm. But imagine if your arm was so small you needed an electron microscope to see it. The hair would be that much smaller. And we're talking about the tip of the hair. So you can't look at it and say, oh, it looks like this and it looks like that. And in fact, we don't even know if this exists. It might not. And the fact that I thought of this, I thought, hey, what if there's one antigen that never, ever changes? If I thought of that, 1,000 people smarter than I have already thought of that as well. And have probably been looking for that. And haven't found it, or it doesn't exist.
Or they don't want you to know because they make more money off of you with these HIV medications.
Who? Who makes money off of the HIV medications?
The pharmaceutical companies. You see all these things now, it's called, they have something called PrEP. They have other things, I guess, that makes you like non-detectable. I see all kinds of commercials for these HIV medications to kind of keep you, I guess, going or not as, or kind of slows in the process of, you know, they say so you can live a better life. Just like those herpes commercials. They got people canoeing, climbing mountains, all kinds of stuff. But there's no so-called air quote a cure for it.
There is not. There is not a cure for it. There is not. There is not. And I'll tell you why. First of all, do you know why the internet was invented? I'll give you a hint. It was not for videos regarding cats. The internet was invented back in the 1960s so that scientists around the world could quickly share information with one another. So what this person was doing today, this person over here knows about the very next morning. And then this person over here knows about the very next morning. And this person over here knows about the very next morning. This person over here knows about the very next morning. This person over here knows about the very next morning. Now, how many institutions, whether they are farm institutions, pharmaceutical research companies, or university institutions around the world are working on human immunodeficiency virus at any given time? 10, 100, 1,000? Probably closer to that number at any given time around the world. But let's say 100. Now, I mean, there's more than that just in the United States working on this. doing experimentation and learning about it and understanding it, et cetera, et cetera. And I don't mean like actually handling the virus necessarily. It could be on paper, but still 100. Of those 100, how many people are involved in each group? Maybe another 100. So 100,000 scientists and researchers around the globe instantaneously, or nearly so, getting the same information. Now, you say, well, this person over here might want to keep it a secret, might want to keep what they know a secret. Well, that's true, but they've been working in this direction for the past year and a half or 2 years. To suddenly say nothing would be weird, first of all, not to mention that this group over here is doing the exact same experimentation. And maybe even this group over here is doing the exact same experimentation, which means they're all going to come to similar ideas at the same time. The idea that thousands of people around the globe working completely separately, because the people who work for the universities don't care if the pharmaceutical companies make more money or not. The people working for the pharmaceutical companies don't care if the universities make more money or not. All they care about is the science and the research. Now you could say, well, the scientist who does all this experimentation, maybe he's just being greedy. Well, that scientist who discovers the cure is going to get the Nobel Peace Prize, which comes with a bunch of money, which comes with a bunch of notoriety, which means they're going to get their name inside of a history book. They're going to have schools named after them. They're going to have a wing of a university named after them, probably several universities. Meanwhile, most of the people in the world living with HIV live below the poverty line, at or below the poverty line. Most patients in the world right now who have HIV live at or below the poverty line. How are they paying for expensive medications if they live at or below the poverty line?
Government assistance.
Yeah, insurance.
What insurance?
State insurance, government, the funded insurance through the state, like welfare.
Okay, I would like to ask someone who did not grow up in the United States that same question. Because there's only 320 million people in the United States. There's 7.5 billion people on the planet. Most places are not the United States. Most places are very much not like the United States. Most places don't have the kind of money that the United States has. You can't extrapolate and say, well, the government pays for all that. What government? In these other countries, in these other parts of the world, what government they don't have money. They don't have money for that stuff. There's no welfare. Let alone,
I'm not talking about like the government that just pulls out their wallet. We pay for it. It comes out of our taxes.
Yeah.
You're still talking about the United States.
Yeah, but aren't other countries taxed?
But also too, I believe that other countries deal with things totally different, and it affects them differently than it does in the United States. Like as far as like our foods and things like that, like all the GMO crap in there, some of that stuff isn't allowed over in France.
Whoa, 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 whoa. Wait, what? You're talking way too fast.
I'm sorry. I was saying, I mean, I get what you're saying about, how do they pay for it? But I think, I mean, HIV is HIV. It's terrible, and like you said, there's no cure. But I do think with some of these diseases that we have in the world, I think it's like I think it's a different effect on some people in certain areas over the world because of their lived lifestyles,
yeah.
things of that nature.
Oh, I absolutely agree. It affects different people all over the world.
So because
where is it high? What continent has the highest amount of HIV right now?
that I don't know.
Africa.
Africa. Yep. And
Africa.
how are those people in those tribes paying for it? That part of it.
Yeah, and and let's look at some of the countries there. Where's that government money?
South Africa, to be specific.
South Africa, yes. Now let's go north. Let's go up towards the Ivory Coast. Let's go just below the Ivory Coast. Let's not talk about Senegal. Let's not talk about Egypt. Let's talk about those other countries where there isn't so much money, but there's a huge amount of HIV.
Do they just not get treatment?
There's no government funding. There's no insurance. And why is there so much more focus right now put on COVID? If HIV is so bad, why is there so much more focus on COVID right now? I mean, is COVID that bad?
It depends how it affects you, I guess. Some people can get it with no symptoms and some people die. So you don't know how you're going to be affected.
Exactly. Also, how does one get COVID?
Is it the droplets?
Is it contagious or communicable?
Communicable.
No.
No?
Contagious.
No, it's contagious. When you think of diseases under the categories contagious, communicable, think contagious means somebody sneezes in the same room that you're in and you get sick. That's contagious. Communicable means there's some kind of intimacy. It doesn't have to be sexual, because a person sharing a needle with another person is still being intimate, or even a person getting a blood transfusion has an intimate connection with the person who gave their blood. That's communicable. So it's much easier to guard yourself against communicable diseases. It's easier than in contagious diseases. Go to Walmart, somebody sneezes on the bread that you were about to pick up. You didn't even know it. They already left the aisle. Or it just sneezes in the aisle. And then it kills people, which is bad. So contagious diseases are often get a lot more attention. Deadly contagious diseases get a lot more attention a lot faster. Things that can be prevented, not as much.
That's why I don't understand how they came out with the COVID vaccine when they don't even know that much about the disease. We're still learning about the disease. So how do they come out with the vaccine to prevent a disease or treat a disease?
Well, because we known about the virus since the 1960s.
Yeah.
The coronavirus is still a coronavirus. It still comes from the family.
Yes, but it's a different strain.
True. But it's still the same virus. It's still the same basic virus, the same basic principle of the virus. Much easier place to start with. The virus for HIV was discovered after the disease AIDS. AIDS was called the disease years before the virus itself was even discovered, which, by the way, happened in France at the Pasteur Institute, still one of the leading institutes in the world when it comes to infectious disease. And yes, they got a Nobel Prize for that. But it's not about money. It just isn't. There's too many people working worldwide, sharing information. You know, you probably heard people, or doctors or somebody talking about medical journals. This stuff comes out in medical journals all the time. And as soon as something comes out, what do you think somebody else does? Well, let me see if that's true. Here's the experiment they did. Here's the parameters they had. Let's see if it comes out the same for me. That's why we never accept one research study as the study that says, yes, this works. There has to be multiple things. This is what science is. Science is reproducible. We have to be able to see the same results doing the same exact things. Otherwise, it doesn't count. So if somebody suddenly says, hey, I have a cure for HIV, nobody's going to go, yeah, yippee, and everybody's just going to quit. Everyone else is going to pick up that stuff and say, okay, let me try this. Let me follow that and see if it works for me the same way. And then somebody else is going to say, let me see if that works, but I'll change some of the parameters a little bit, see if it still works the same way. And you certainly can't discount other countries and their populations in the world with how they handle things. That's true. And then who said GMOs? That's the worst thing ever. GMOs.
I said it. I said it.
Say it like that. Guilty. GMOs, genetically modified organisms. Do you know what we are? People?
No, full of sin.
We are genetically modified organisms. How do we genetically modify ourselves? Well, what we try to do is we try to meet people who we find attractive, and attractive often relates to things like good health. That's at the biological level. You know, the sickly animal in the herd is not going to get the mates like the healthy stud buck is going to get the mates. So they're going to have less of a chance to pass on their genes. So what we look for subconsciously is someone with good genes that we're going to pass on and have children with, pass those genes on with. We don't do it, well, kind of consciously. We swipe left or right. I don't know which is which, but I know one of them means you don't like them. The other one means you do like them. But that's what we do. And we try to find the best person to pair up with and create the best offspring. We are modifying the genes as we go along. Now, if you look at corn, for instance, there isn't a corn that exists on this planet that existed 400 years ago or 500 years ago. Why not? Well, because we took corn that maybe was growing hardier, like bigger, for instance, and then we took other corn that may not have been growing as bigger, but had something about them that caused insects to dislike them. And we combine those corns together. And we make a corn that insects don't like as much, but grows bigger. And then we modify that again, and we modify that again. Look at the dogs. How many dog breeds are there? Why are there so many dog breeds? Well, because some people like little tiny purse dogs. So when people like little tiny purse dogs, there's a market for little tiny purse dogs. So people get little tiny purse dog females and they mate them with little tiny purse dog males, and they get the smallest little tiny purse dogs. And that goes true with dogs that are, some are better for hunting, some are better for herding, some are better for guarding. And that's what we do. So we've been genetically modifying everything. Doesn't mean that it changes anything when we eat that corn. It doesn't mean that we're worse off. It doesn't mean that we're not, it's somehow changing our genetics. It is not. It's just one of those new things that people have found to complain about. And they think are terrible things and are not. But again, all I'm doing is following the science. That's all I can do. Got a little off topic there for a bit, but that's okay. Oh, I didn't even mention this part. Didn't even get to this yet. When I talk about antibodies, I want you to know this because you'll hear this term. Antibodies are also known as immunoglobulins, or simply abbreviated IG. And there's IgM, IgA, IgD, IgG, and IgE. That's how I remember it, MAG. All of these are found in the blood, except IgA is going to be found mostly in body secretions. Look at the color I wanted. Like tears, saliva, breast milk. IgG is the only one that crosses the placenta. In other words, goes from mom directly to baby. So now you can see baby's going to get some immediate immunoglobulins, IgG, and if mom breastfeeds, going to get some additional immunoglobulins, an IgA. These two working together, actually, in what we call the classical pathway of immunity. IgE is involved with allergic reactions. IgD has unknown cause or unknown function. So antibodies are also known as immunoglobulins. Remember, antibodies are Ys. They look like the letter Y. They actually do have that shape. Antibodies, also known as immunoglobulins. Immunoglobulins, also known as antibodies. And immunoglobulins is abbreviated capital I, small g. Okay, so neutrophil. Eosinophil, I talked about those. Eosinophil, if you don't know how to pronounce it, you pronounce the E, then you pronounce the O, then it's a sinophil, eosinophil. Basophil, histamine, heparin in the blood, important to realize. Lymphocytes, smallest of the white blood cells, most specific for viruses, T cells and B cells. And monocytes are the other type of agranulocytes. Didn't get to that. Monocytes are going to become macrophages. A monocyte, that's a monocyte. You can tell because it has that big kidney bean-shaped nucleus. And a monocyte is going to become tissue specific. It's going to go to the lungs or the skin, which kind of makes sense because then it's going to hang out there. And these white blood cells are going to help out with, well, all these different reactions, all these different infections, all these different problems. Where do white blood cells come from? The same place as the red blood cells. They all come from that hematopoietic pluripotential stem cell. Platelet the thrombocyte. Thrombocyte is a platelet. They are active in the blood clotting process. So if we have our blood vessel here, and blood is traveling through it, and there's some kind of a break in the lining of the blood vessel. So you can see the lining here is broken. That is going to trigger platelets to start to stick to the area and stick to one another. Platelets will stick to the area and start to stick to one another. And as you can see, what's going to happen is they're going to end up forming a little bridge or a little dam that's going to block the blood from leaking out. And then we have clotting factors that come in that create a nice strong clot. These clotting factors that are released from the injured tissue, or they are floating through the blood, they're going to come in and continue with this, make that nice strong clot. And that is going to allow the blood to continue through without leaking out. That's what we want. However, what if a person has some cholesterol plaque built up here on this lining? Well, that is damage to the blood vessel lining, and the platelet doesn't know the difference. All the platelet knows is that there is damage to the blood vessel lining, so it's going to start to stick to it and stick to each other. And over time, you can see how this is going to create a blockage, which is going to decrease the amount of blood going through there. And if this is happening in a coronary artery, that means a decreased amount of blood going to the myocardium and the muscle cells of the heart specifically, which is going to cause them to start to slow down, make less energy, and eventually die, leading to things like a heart attack. So if a person has clots like this forming in their body, one of the things we can give them is aspirin. Remember the abbreviation for aspirin, ASA, acetylsalicylic acid, the abbreviation for aspirin. So why would we give them aspirin? What does aspirin do? Well, if we look at a platelet, here's our raggedy platelet. Our platelet is activated so that anytime that platelet comes in contact with damaged endothelium of the blood vessel, it's going to stick to it. And it's going to stick to other platelets and make a clot. What aspirin does, aspirin turns this off and then breaks the switch, so that platelet can never get switched back on again for as long as it lives, which is about 7 days. It's not going to make that clot smaller, but it is going to stop it from getting worse. This is why patients who are making lots of clots and have concerns about potential heart attacks might be on aspirin a day therapy, 81 milligrams, because we don't want them to make more clots. But what if that person then finds out, oh, I need to have my gallbladder taken out? Well, the surgeon will say, stop taking aspirin today, and we'll schedule the surgery for next week, a week later. Because then all the platelets that have been exposed to aspirin will be gone, and they'll have new platelets, which means when they go into surgery, the surgeon's going to want them to clot. They're not going to want them bleeding all over their surgical theater. So this is one of the things that has to be weighed out. You have to consider, well, is this surgical procedure important enough to take them off of the aspirin therapy for that much time or not? Lifespan of a platelet, about 7 days. This is why if a patient is at home and complaining of chest pain, says it feels like there's an elephant sitting on my chest, they have difficulty breathing, maybe they have pain radiating to their neck or to their back or to their upper neck, upper back, or to their left arm, have a feeling of impending doom, maybe they're diaphoretic, they're sweating profusely, even though they haven't been doing anything, and you call 911 while you're waiting for the ambulance, you get 2 of those uncoated baby aspirin and have them chew them up. Because if that person's having a heart attack, we want to stop platelets from continuing to clot. Keep that blood flowing as much as possible. Platelets, thrombocytes. Oh, wait. Hemostasis. Do we want hemostasis? Do we want the stoppage of blood flow? Yes, if it's leaking, but if it's just generally speaking in the body, no, we don't want hemostasis. We want blood to continue to flow. That's why we say things like, if you're sitting for a prolonged period of time, get up, get your blood flowing. Because when blood stops moving, clots are forming. So we want to keep blood moving, but if there's a leakage, if there's an injury and blood is leaking out, then we want hemostasis. Seven days. Oh, and then finally, blood types. The ABO system. Okay. Now, if you consider all the cells in our body, cells that make up our kidneys or our livers, if we have more than one, if you consider cells like this, they are going to have thousands of different types of antigens. There are going to be things sticking out of those cells that are so unique to us that we won't find another person with an exact match, perhaps anywhere on the planet. There's so many possible arrangements of these antigens sticking out of our cell and most of our tissues. It's just impossible that we'd ever find somebody who has the exact same tissue match. So we try to find somebody who's close. So when somebody needs a new kidney, we say we got to find a match. Actually, we're not looking for an exact match. We're looking for a close enough, because that's all we're going to be able to find. However, when it comes to blood, blood is simple. It doesn't have that many options. And here's how you can tell. When the person was first experimenting with red blood cells from humans, and this person realized that there were antigens, although I think at the time they called them side chains, that were sticking out of the cells. He basically discovered there's 2 types of blood cells. That's it. There's only 2 types of red blood cells. So he did the simplest thing and called one type, type A, and one type, type B. Easy. Until, of course, he then found another type. Now, the problem with this type is it did not have any side chains coming off of it. So what do we call this one? Well, it doesn't have any side chains, so he called it the one with, he called it the one with 0 side chains. But he already started using letters, so what letter looks like a 0? Oh, it doesn't have those side chains sticking off of it. So now there's 3 types of blood type. Okay, that's not too bad, A, B, and O. Later on, the more rare type was discovered that is a combination of A and B. See, people knew for a long time that if you lose a lot of blood, you die. So they tried things. They tried putting blood back into people. Hey, there's a dog over there. Get some of that dog blood and put it in. Hey, there's a sheep over there. Get some sheep blood, put it in. Get that goat blood, put it in. Guess what? Nothing worked. They said, oh, we must be human blood. So they start using human blood. And every once in a while, it would work. Every so often. So when this guy started experimenting with this, he said, well, there's 2 basic blood types. Oh, no, wait, there's 3 basic blood types. And like I said, later on, the 4th one came along. So here's the fun thing about this. If a person has type A blood, they are going to make antibodies against the thing they don't have. Well, they don't have Bs. So a person has type A blood, he's going to make antibodies against anything that has a B on it. So a person with type A blood can only get type A blood. He can't get type B blood because those antibodies will stick right to it and everything will clump together and he'll die. He can't even get type AB blood because, well, I put the B in the wrong place, because type B blood, type AB blood, he can't even get this type because it has B's on it. And if you put that red blood cell into that person with type A blood, those antibodies are going to stick to those B's and everything's going to clump together and he's going to die. But wait a minute. Type O doesn't have any of those. So type O can go into that patient. So we can take the red blood cells from the type O patient and put them in the patient with A blood because, well, it doesn't have anything coming off of it. So there are no antibodies against it. So if a person has type B blood, they're going to make antibodies against what they don't have. And what don't they have? They don't have A. Which means if you put a red blood cell in that person that has an A on it, it's going to clump together, they're going to die. That way, a person with type B blood can only get type B blood. But wait a minute, type O doesn't have anything sticking out of it. So that person with type B blood can get type B or they can get type O. Now, here's a problem. A person with type O blood is going to make antibodies against what it doesn't have. And what doesn't it have? It doesn't have A's, but it also doesn't have B's. Which means the patient who has type O blood, if you put anything in that person, in their blood, that has an A or a B on it, things are going to clump together and the person's going to die. Well, everything has an A or a B except for type O, which means a patient with type O blood can only get type O. But that type O blood cell can go to an A or go to a B. And look at this last one. He's going to make antibodies against what he doesn't have. But wait a minute. He has A's and he has B's. So he won't make any antibodies. which means he can get type O blood, because type O blood can go anywhere, but he can also get type A. He can also get type B, or of course he can get AB. So if someone were to ask me, what kind of blood type would you like to have? I would say, please give me type AB, because that means I can get blood from anybody. I'm what you call a universal recipient. You can put any of those blood cells into me and I'll be fine. But nobody's going to want my red blood cells, because if I put any of my red blood cells into anybody else, it won't work. So that's the selfish one. AB is the selfish blood type. Type O is the universal donor. Lost the word for a minute there. Type O can go into anyone, but type O patients can only get type O blood. This is why patients who have type O blood are always getting requests from blood banks. Hey, you want to come in and give us some of that type O blood? Because we can use it for anybody, and patients with type O can only get type O. So it's really the one that we want to have a lot on hand. And that worked out really well for a while, until this guy was doing some experimentation on the blood of rhesus monkeys, not to be confused with rhesus pieces. And what he found was on the red blood cells of rhesus monkeys, and of course later on humans, there were groups of antigens that were really small. And something I told you a while back, when we were talking about cell membranes, if there's a big difference, the immune system will put up a big attack. If there's a small difference, then the immune system puts up a small attack. That's why these tiny antigens were overlooked for so long. And we call these the rhesus factors. And we'd say that that person is type A blood rhesus factor positive, or Rh positive. Or we might just say they're type A positive. And if they're absent, then they are rhesus factor negative. Like we'll make this type B the rhesus factor negative. They're either there or they are not. If a person has a type rhesus factor positive blood, then it doesn't make a difference if the blood they get is rhesus factor positive or negative. Doesn't make a difference. However, if the person has a rhesus factor negative, then they have to get blood that is also negative, because they'll make antibodies against what they don't have. So anytime, I always suggest to people when they're learning this, always start out with 4 red blood cells, a type A, a type B, a type AB, and then the type O. And then write out what type of antibodies they would create. And it's easy. They're going to create antibodies against what they don't have. Type A will create antibodies against B. Type B will create antibodies against A. Type O is going to create antibodies against both because it doesn't have either of them. And type AB won't make any antibodies. And do that part first. Then determine if the rhesus factor is there. If the rhesus factor is positive, if it's there, then it doesn't make a difference if the blood they're getting is positive or negative, because they're not going to make antibodies against it. But if they are rhesus factor negative, then they will create antibodies against it, which will create an immune response. So if mom is pregnant and she has a baby, and that dad had a negative blood type, that baby's probably gonna have a negative blood type. That's not a problem because mom's blood and baby's blood don't mix until labor and delivery. Well, now when that placenta's separating and some of baby's blood's leaking and mom's blood's leaking and now they're mixing together, now mom's going to start making antibodies against that rhesus factor, or that, wait, dad's was positive, mom was negative, against that rhesus factor. Yeah. So when she has another baby with the dad, we want to sort of suppress the immune system a little bit. So that she's not going to make any antibodies against that, if we can help it. Start off here. That's that ROGAM that you've probably heard of in the past. I have my lab book here. I remember to grab it very quickly. If you haven't already done some of this, the endocrine system, they do point out here, this is a microscopic slide of the adrenal gland, and you can see the cortex, and it does actually list the different zona layers. It didn't have them in the slide, but it has them here. The zona GFR, zona granulosa, zona fasciculata, zona reticularis, zona granulosum, zona fasciculata, zona reticularis. And then there is a really nice image labeling the endocrine system, which is good. So again, if you haven't done this, you really should. I know we're out of time here, but also notice these blood smears. So how does one get a blood smear? Well, you get somebody's finger, you stick it with something sharp, and you drip their blood onto a microscope slide, just one little drip of it. And then you take a slide, you smear it across, put a cover sheet on it, and you end up with a microscope slide covered in blood. So when you look at this microscope slide covered in blood, what you're seeing in this image is not the entire microscope slide. What you're seeing is one tiny little area of that microscope slide that had just one tiny little drop of blood on it. And you see in this picture here, for instance, you get a whole lot of red blood cells. You got a couple of white blood cells. Oh, I even see a platelet. It's right around there. And what you don't see, but you actually do see, I know it kind of sounds weird for me to say it like that, is the plasma. Remember the fluid portion of blood? All these areas in between the cells are all filled up with that plasma, as well as on top of all the cells, as well as underneath all of the cells. So there's plasma all over there. You kind of just can't see it though, because you're looking through it. So make sure to go through and you can see some of these different microscopic evaluations. And it points out what some of these different cells are going to look like underneath the slides. Notice the red blood cells don't have a nuclei. Notice the white blood cells, however, do. Okay. Well, I appreciate your attention for today and your input and your attendance. So does anyone have any questions before we end the day? If not, I will say this. If you don't have any questions, I will see you next week, I suppose. Make sure you get those chapters done. I'll have a quiz next week. We're not going to have one this week, obviously, because we were behind and we didn't have any new material anyway. So Next week, there'll be a quiz over probably the blood and white blood cells. I think that's a good idea. Maybe endocrine too. Maybe I'll throw some endocrine in. Be endocrine and blood over these 2 chapters. So be prepared for that. And that's it.
I have no questions, but a great discussion today. I really enjoyed class.
I love it.
I was in there with you today.
That's awesome. That's what I want.
Yep.
Cool. All right. Well, if you don't have any questions, have a good rest of your day. If you do have any questions, you can just stay on and I will still be here.
Dr. Surgeon, I just have a question not related to class, but I
Is it
re-emailed
going to be
you.
a question I can answer? Or
Yes, yes. This
ask
is a
something?
really easy question.
What is the meaning of life? Oh, yeah, that's a good one. Hold on.
Of my life in particular.
I'm going to pause recording, so we'll just stop right there.